All right, it's wonderful to see you all in person with us today and also virtually from around the world. Thank you for making the time to be part of this convening. We're thrilled by the scale and reach of today's gathering. We're welcoming nearly 400 registered attendees, both in person and virtually. Participants represent 8 countries as well as more than 33 states. With that, it is my pleasure to turn things over to Dean Galea.
Thank you, Courtney, and thank you to everybody for joining us in person and online. I'll frame the event in a second, but first, I would like to introduce our opener, our Chancellor, Andrew Martin. So Chancellor Martin is the 15th Chancellor at Washington University in St. Louis since 2018. And under his leadership, I think the university has entered a really exciting new era of impact and opportunity. In his inauguration, Chancellor Martin outlined a bold vision to elevate WashU's academic distinction, to expand access to its world-class education, and to strengthen the university's partnership with the St. Louis region. That vision eventually came to life with the launch of WashU's strategic plan, Here and Next, which has guided the university's priorities for the future. One could talk a lot about the strategic plan. One of those elements was the creation of the School of Public Health that is co-hosting this. But one of the other elements was Make Way, our student initiative, which was an effort to remove barriers to student success by expanding scholarships, fellowships, and personalizing support. This work builds on programs like the WashU Pledge and Gateway to Success, which helped the university transition to a need-blind admissions in 2021 and has had a remarkable effect in opening doors for all talented students at WashU. In addition to his leadership, we could talk a lot about that. Chancellor Martin is an accomplished scholar and professor of political science, law, statistics, and data science. He's a proud WashU alum, earning his PhD here before serving in leadership positions at both WashU and the University of Michigan. Chancellor Martin, welcome.
Thank you, Sandro. Good to be with you all today. On behalf of Washington University, it is my pleasure to welcome you to campus and to this important symposium, Race, Reason, and Health. We are grateful that so many scholars, practitioners, community partners, and students have joined us for what promises to be a thoughtful and important conversation. The question of how race shapes health outcomes remains one of the defining public challenges of our time. Understanding these disparities and addressing them requires the careful combination of rigorous evidence, ethical reflection, and engagement with the communities most affected. Universities play a crucial role in convening the kinds of conversations that can move understanding forward. The collaboration between the School of Public Health and CRE2 exemplifies the kind of interdisciplinary engagement that allows institutions like ours to address challenges that cannot be solved from within any single field. I want to thank Dean Galea, Dr. McBride, and their colleagues for organizing today's program and for bringing such an extraordinary group of voices together here in St. Louis. With that, let me welcome you once again to Washington University and to the symposium Race, Reason, and Health, and I'll turn the program back over to Dean Galea.
Thank you, Chancellor Martin. So before I begin and make a few remarks, I would like, first of all, to thank everybody who made today happen. An event like this, particularly when it's being co-hosted by 2 units, has a lot of people behind it. And so I want to, without naming anybody so I don't miss anybody, I'd like to have a round of applause for everybody who made today happen. Thank you. A particular note of thanks to our partners at CRE2 and to Professor McBride, who has been really an outstanding partner and colleague ever since we've been moving forward with the School of Public Health, and we've been very grateful for your friendship. Thank you. So let me talk a little bit about today. So we're convening about race and health. So I want to be direct about this from the start, not because the topic is new, because the topic is not new, but because the way we talk about it matters. And too often in academic settings, we soften the language to the point where it loses its meaning. So racial health inequities are among the most persistent facts in American public health. They have been measured, they've been documented, they've been debated for generations. We have more data than ever, more sophisticated methods, more publications, and yet gaps persist. And in some cases, they have widened. So the question that brings us together today is not whether race matters for health, that is settled. The question is what we are going to do about it. and specifically whether academic research and community partnerships can produce knowledge that is not only rigorous, but actionable. Knowledge that does not merely describe health gaps, but helps dismantle them and break the structures that produce them. So the ambition of this convening is to help us grapple with those questions. It is a partnership between our School of Public Health and the Center for Community Research and Engagement, and their partnership is intentional. If the evidence we produce does not reach the communities it's meant to serve, then we have failed, not partially, but entirely. And we have a number of outstanding speakers who are going to lead us in that conversation, and I'll start off by introducing our keynoter. Dr. Mary Bassett really in many ways does not need an introduction in public health circles, but I want to offer her one anyway. Her career, Dr. Bassett's career, is a living argument for the very premise of this convening. Mary is a physician, epidemiologist, and FXB professor of practice and human rights at the Harvard T.H. Chan School of Public Health. She has served as health commissioner for both New York City and New York State. I think you're the only person who's done that, who's held both positions. She spent 17 years on the medical faculty at the University of Zimbabwe, building HIV prevention programs during one of the worst epidemics in human history. She has led programs at the Doris Duke Charitable Foundation and the Rockefeller Foundation, and she's a member of the National Academy of Medicine. But here's what I want you to sit with. Mary has published some of the most important scholarship in our field on racism and health. Her work in Lancet, New England Journal of Medicine, has fundamentally shaped how we understand the mechanisms, not just the existence, but the mechanisms through which racism produces health gaps. She has argued, and the evidence supports this, that structural racism can be described, measured, and undone. And Mary's work has made it clear that's not a slogan. It is actually a research program that leads to actionable, nonpartisan steps that create a better country for everybody. She has done all this work while insisting, sometimes at considerable personal cost, that public health must speak plainly about power, about history, and about the obligation to act. She wrote early that the challenge for public health was not to remain silent, but to speak up. She wrote that in 2015, and I think it's more relevant today than it was then. So we're not beginning this convening with a neutral voice. We're beginning with someone who has spent 4 decades showing that scientific rigor and moral clarity do not have to be in tension, and in many ways, they're often inseparable. Dr. Mary Bassett is also a longtime colleague and friend, so I'm delighted to host her here. Dr. Bassett, Mary, welcome.
Well, thank you for such a kind introduction. I'm always sort of stunned at the number of jobs that I've had, but we miss Dean Galea in Boston, where he was really a beacon for the idea that public health is rooted in social justice. So thanks for having me here today. I'm very grateful to the Center for the Study for Race, Ethnicity, and Equity and the School of Public Health. And I'm especially grateful for its ongoing commitment to the pursuit of equity, which has been an unbroken thread in our field and in my working life. So it's also a pleasure to be here in the heartland, where spring has arrived, unlike chilly Boston. And St. Louis, looking over St. Louis as I was headed here, I learned that it used to be called the Mound City, a reference to the fact that the city sits on land that was part of the Mississippi civilization, the Mound culture. And of course, Missouri was at the center of the debates around the extension of slavery in the United States, so there's a lot of history here. This is how you have framed today's symposium, and it's probably on your cards in front of you. It is, of course, true that we need innovation, we need respectful engagement, we need community involvement in order to achieve impact. This is always a laudable goal, but we are also in very unusual times, to which I think Dean Galea referred. Consideration of the enduring impact of race and ethnicity on health is now being treated less as a fact than as a divisive framing of our reality. And more broadly, we've seen threats to the biomedical research infrastructure, to global health, scientific expertise, and indeed threats to competence. This has also affected the university where I work. Harvard has also undergone changes, even as the leadership has so far not made a deal with the federal government and recently has been forced to continue legal challenges in its effort to maintain federal funding. This was a large poster in a laboratory overlooking a quadrangle, which was removed by custodians in the spring of last year. I think you can make out that it reads Black Lives Matter, which I should hope we all agree is an important statement. They just recently got the permission to put it back up, but we are all witnessing a backlash to what some of us refer to as the racial reckoning, a reckoning that had twin roots. First, the really shocking disparate impact of COVID on life expectancy in our country, where really the most alarming to me, and I won't be talking about it much today, is the impact on people classified as American Indian and Alaska Native, whose life expectancy fell below 65 years. Only Haiti, the most impoverished country in our hemisphere, has a life expectancy on that level. And of course, there was the murder of George Floyd, and together these spurred a change that we can also see in the published literature. This is a PubMed search using the word equality, and we see a change. I don't know if it was an increase in the volume or the way we talked about it, whether it was a change in language or in activity, but in any case, we saw a surge in the use of equality, a surge in the use of the word health equity. I mean, that's really very striking before, and clearly related to the 2020 shift in the American disposition. Before you get too excited about that ski slope, just remember that there are about 1.5 million citations added to PubMed every year. We also saw the addition of the word racism. We saw the addition of health inequity, health disparity, and even white supremacy has made it into the public literature. So if you ever doubt that how we write and how we talk is affected by our political context, I hope that these graphs show you the shift that we see. And if you noticed a decline, you would be correct. We are now seeing the use of these words going down, and at the same time, we now have a director of the NIH, Dr. Jay Bhattacharya. I really like that we've all had to learn how to pronounce his name. We have to remember that this is a very diverse country, and there are names that English speakers may not be familiar with. In any case, he's the NIH director. He's also currently acting director of the CDC, and he is extremely averse to the construct of structural racism. So I'm going to take some time today, because I think it's important to go over why we use this word and how it is rooted in history, because he has declared it an unscientific and ideological construct. So in thinking about how I wanted to use my time with you today, I think that we all have an obligation to consider how we got here. Lydia Polgren, I don't know if you read the New York Times in these parts, but she's a columnist for the New York Times. She wrote a piece titled, "Is it Trump or is it America?" A very challenging title, I would say. So we need to think about how we got here. We need to think about why that we see such an enduring impact of racial ethnic classification on all areas of health, including the length of life itself. We have to think about our obligation to have respect for and elevate the voices of the people who bear the burden, because if they are not committed with us to addressing this, then who else is better placed to be part of this effort than the communities that bear an excess burden? There's not been a single year since the collection of vital statistics, even before this country was a formal nation, when people of African descent haven't had sicker, shorter lives. So to call it persistent is maybe a bit of an understatement. This is, part of the warp and weave of public health in this country. And of course, I'm going to end up with saying a few words about the importance of social movements in the ways in which public health has divorced itself from social movements, which I don't think is required by our commitment to evidence, excellence, and equity. So that's what I'm going to do. I've been at this for a long time, as Dean Galea suggested. This is from a paper that I wrote with Nancy Krieger 40 years ago. I was a graduate student at the time. I was getting an MPH. And we wrote, and I'll read here, the facts of being black are not, as these models, the environmental and the genetic model, a genetically determined shade of skin color or individually deprived living conditions or ill-informed lifestyle choices. The facts of being black derive from the joint social relations of race and class, how racism disproportionately concentrates blacks in the lower strata of the working class and causes blacks in all class strata to be racially oppressed. So I have never changed this position, and I'm going to talk with you about it today. The roots of this, when the story began, is with the transatlantic slave trade. And yeah, you can see it here. This was a trade that went on for several centuries, resulted in the removal of, some say, over 13 million people from the west coast of Africa. Many lives were lost in the crossing, over 1 million lives. You would think that they might have taken more care with such, valuable cargo. And the thing that always strikes people about this map is that skinny arrow going to North America. Under 5% of the people trafficked across the Atlantic Ocean from Africa went directly to the United States. So in the process of this crossing, which would result in 250 years of enslavement, followed by 150 years of unequal treatment, on the Atlantic was where people of various African nations stopped being members of their nations and became black. This is where the racialization of the black identity occurred, and people became a racialized group. Now, this was not a passive process. There were many uprisings. Over 300 have been cataloged, and this graph gives me a chance also to remember that the land that became the United States was land that was conquered from indigenous people and with basically a genocidal campaign against the indigenous of this continent. But I think that it's important that people realize that this was not a peaceful process. Not only were there organized uprisings, but there was household level resistance, poisonings, fire. And by the time the enslavement ended with the Civil War, still the bloodiest war fought by the United States, there were 4 million people who were emancipated, up from 400,000 at the time that the United States became a nation. And the growth of this population was almost entirely through natural growth. In other words, the importation of enslaved people stopped. And their loss of 4 million people, the largest single source of capital for the South and the nation, was huge for the U.S. South. Mississippi went from being the wealthiest state to this day, the poorest. And of course, the people who were emancipated received their freedom and nothing else. So I like this graph because it shows sort of a picture of the United States and gives us the idea of the green bit in context. I would date the green bit from the mid-1960s, when the Civil Rights Act and the Voting Rights Acts were passed. But in any case, that's Brown versus Board of Education. You can see that most of the U.S. history, in terms of the positioning of people of African descent, has been red or yellow, and the green period is relatively short. And I thought I would just read this quote to you, or show this quote to you from LBJ, who ushered in the Civil Rights Act, the Voting Rights Act, and at great personal cost politically, I might say. He was a Southerner from Texas. And he went on to say in this important address that he made at Howard University, he noted, "You do not take a person who for years has been hobbled by chains, liberate him and bring him to the starting line of a race and say you are free to compete with others and believe that you have been completely fair." This was said by a sitting president of the United States. And then he went on at the end of his speech to say, "To this end, equal opportunity is essential, but it is not enough. Not enough," he repeated. And there may be a bit of gender bias in this, but he went on to say, ability is not just a product of birth. Ability is stretched. I can't read it all from the back of the room here. Ability is stretched. There's a line through it. But anyway, it's affected by not only who you are, but by the ability is stretched or stunted by the family you live with, the neighborhood you live in, by the school you go to, the poverty or richness of your surroundings. It is a product of 100 unseen forces playing upon the little infant, the child, and finally the man. And I would say he was basically arguing for structural racism as a construct. So I'm going to turn now to talk about what the Health Department put forward in the article that was mentioned. It was published nearly 10 years ago. And I'm very proud of the fact that it came out of a health department, that we proposed the idea of structural racism as having this taxonomy, including internalized racism, interpersonal racism, institutional racism, and finally structural racism. This shows internalized refers to how we think about ourselves. This little boy is looking at the brown doll while he selects the white doll, the famous doll experiment, as he's asked to pick the one that had good attributes, and he is obviously looking at the black doll as he picks the white doll. Next is interpersonal racism, which is what most of us think about when we think about racism, the way in which people interact with each other. It includes both implicit and explicit bias. I think we have to remember that bias is not only implicit, we still have plenty of explicit bias. And finally, institutional racism, which was coined by Stokely Carmichael, as he was then called, and Charles Hamilton over 50 years ago. This is little Ruby Bridges being led by federal marshals into a New Orleans elementary school. It didn't matter whether her principal of her school or the teacher with whom she ended up having a nice relationship wanted to have her there. It was the rule of the land that she, until Brown versus the Board of Education, didn't have the right to be there. So this is what we mean by institutional racism. And finally, structural racism, which has a long and very fulsome definition that is given here. It refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources. And we sort of laid out that this is a definition. Other people have other definitions. There's no single accepted definition of structural racism, but the key part of all of these definitions is that racism is not simply personal. It's not just the accumulation of 1,000 private prejudices. It is produced and reproduced by laws, rules, and practices, and gives rise to a culture which endorses Black inferiority. And we laid it out like this, seeing structural racism as the platform that supports other forms of racism, which is antecedent to social determinants of health, and thereby gives rise to the inequities in health that we have all witnessed. And I'm not going to go over the data with you. I assume that you're all familiar with the many ways. I'm going to focus mainly on premature mortality. But this is a part that is, I think, very important, that those boxes contain a myriad of pathways, and it is our job as people who work in medicine and public health to unravel how structural racism is working. We can't simply invoke it as some kind of miasma and say, oh, it's all due to the social determinants and structural racism. We have to break it down. And it can work, obviously, a great deal of the way in which racism works is through poverty and through the deprivation related to unequal economic resources. But there are many other ways that structural racism works. And we have the job to figure out how they all work. The exemplars that we often use, and ones that I wrote up with some of the fellows at FXB, are, often it's redlining is given as an example. And the reason to use these examples is they include multiple institutions, not just one institution, that's institutional racism, but redlining required the government, the banks, real estate developers, codicils that were written into residential living arrangements. And there are other examples, and I'm probably going to I'm just going to deviate a little bit to give you one example of healthcare, because we so often talk about inequities, and healthcare is related to interpersonal dynamics, the ways in which a provider responds to a person of color in their care, and that lead to unequal treatment, either unequal diagnosis or unequal treatment. But there are other quite structural ways that the healthcare system differs. And this is an example, since I should take my hometown, my adopted hometown. This was a brand new spanking building at Mass General as compared to Carney Hospital, which is actually now closed. It was bought out by by one of these equity firms and went bankrupt. But this is just to point out that Black-serving hospitals have far fewer resources. They don't have the same kind of equipment. They don't have the same kind of capital. They don't have the same kind of staffing levels. They don't have the same number of experts. So in spite of the loss, the end of legal segregation, which these doctors were protesting against back in the 1960s, we have just 5% of U.S. hospitals caring for nearly half of Black patients, and 3/4 of Black infants are born in 1/4 of U.S. hospitals. So structural racism is not a thing. It is a construct, and it's our job really to unpack it, and this process very often should involve the communities that are bearing the burden of unequal access to care. So I'm going to take a minute to talk about the way in which the New York City Health Department, when I was commissioner, obviously I really liked this job, was how we began to think about community involvement, because I think it's important that we acknowledge that communities have the communities that we are seeking to support have a lot of things on their plate. And we shouldn't just assume that everybody wants to spend a huge amount of time working with us on a project. We're paid for this. We're trained for it. Our responsibility is to do it. And so you can see I circled it in red there. And that shared leadership, we found, is very rarely, well, I won't say rarely, it's not the most common form of community involvement. Because of the demands that having community involvement places, that we shouldn't assume that this is sort of the gold standard for community involvement. I'd be curious, maybe we'll have a little time, although I think I'm going too slowly, to talk about this. But next comes the idea of collaboration. That's one over from the right. And this is when we have engagement of members of a community in which we're directing our efforts from the beginning, from the framing of the question, the development, all the way through. And probably the most common we decided for the health department is the notion of consultation. We never should conduct new programming without giving the opportunity for communities to raise their questions and concerns, and to give us feedback. So we've done our work of identifying a problem, showing why we believe it's important, and then we turn to communities to say why we think this is important, and then we proceed to ask if this makes sense. Do you have anything you want to add? Are you concerned that we've done this the wrong way? In other words, that kind of feedback is something that we should all aim for, in my view. And the last one, I think, is probably the most common way that information goes from between communities and either academic or government public health people. It's called outreach here. That's just sending the information out. It's a one-way process. I'm not saying that's bad. People should know where to get vaccinations, for example. But we know that it's the amount of success that we've had with these one-way communications is limited. All right, so in looking at this document, which remains on the Health Department website, I don't know if you'll be able to read this, but I thought it was interesting that it did go over the language we use, and I thought I would share it with you today because this seems like something we can absolutely do. And that includes what we all refer to as people-first language. We never refer to people as their condition. We always refer to people with a condition. Nobody's condition describes their whole being. So we shouldn't use diabetic, asthmatic. I first learned it when I was chided not to use the word addict. So that's one part of it, but they also go on to point out that, and this was done by a working group at the Health Department about a decade ago, that we should not use language that describes as static the conditions of communities. So rather than calling a community underserved, we should point out the policies and practices that led to that community being underserved and describe it in that way. So I found this useful and probably something that we should all consider. The word minority shouldn't use. We should actually talk about the people, the groups with which we hope to focus on. I think it's a really complex question of how to pursue responsibly community involvement, but it's one that in which we should have minimum standards that involve the opportunity to raise questions and concerns. Now, I'm going to turn to this graph, it was published in 2008, because I want to use premature mortality as what I would argue is, and many of you may work on specific conditions that drive premature mortality. This is death before the age of 65. As over time, using a measure of economic resources at county level as a way of tiering these mortality experiences by both race and income. And you can see here that the group on the bottom is people classified as white, and the group on the top is everybody else. At the time, the racial classifications were inconsistent, so the authors just use white people and everybody else, or people of color. And you can see that until where that red circle appears, these were non-overlapping experiences. And it was only in the early 1990s. We've redone this analysis recently using the classification black and white. And there it wasn't until the 2000s that the highest income quintile of people classified as everybody but whites, that include Asians and so on, overlap with the lowest income quintile of whites. And the other thing that appeared in this paper that continues to amaze me, really, or I guess I should say shock, is what happened with this achievement of stable life expectancy, meaning that it never went below 65 again. And you can see here that Black men only achieved a stable life expectancy. I used to make audiences guess but I won't do that today in the interest of time, until 1995. So that was 40 years later than black women, 50 years later than whites as a group. And so the mortality experiences as premature mortality has been deeply racialized across our history. And then this is sort of a recent obsession of mine, so I'll try and whiz through it. But the US is in trouble, more generally, leaving apart racial ethnic differences. This is our life expectancy experience. So life expectancy is driven by premature mortality. The higher your premature mortality rate, the lower your life expectancies. So the U.S. began departing from the pack of wealthy nations, something after the 1980s, and began its own trajectory. This trajectory looks even lonelier when you take into account how much we spend on health care. That's the U.S. in a red line against a whole host of wealthy nations. This is the inflection point was sort of 1980. This is what happened back to mortality rates. Following 1980, the U.S. sort of left the middle of the pack, and its mortality rates are still going down. Let me be clear about that. But it began to have, relative to others, higher and higher mortality in this century, began to flatten, and as that's COVID there, where we see a real uptake, which was experienced by every nation, but the U.S. did worse with COVID than any other wealthy nation, with a million people's lives lost. But we've been losing people compared to other wealthy nations before this. This is work done by Jacob Bohr, who was at BU, who's still at BU. There, even before COVID, compared to other wealthy nations, if we'd had just the middle of their mortality experience, we would have had 600,000 fewer deaths, and it went up to a million. And here, this is important, not just because it breaks down by race, ethnicity, the ways in these are mortality rate ratios. Everybody knows what that is. This is comparing the middle of the pack of other high-income countries to the United States. So the higher the number, the bigger the difference is. So the way you would interpret Native Americans there is that they have more than 8-fold higher mortality than as compared to the middle of the pack of other wealthy nations in midlife. But what really interests me about this cluster of graphs is that the bulge is all happening in young adulthood to midlife. That's where we're really losing people. And this is something that I think should worry us all, even compared to the United Kingdom, which doesn't do great on many things that many of you may work on, like obesity and heart disease. The US, across our income distribution, is doing worse than the UK until we get to the top 1%. And this is not just limited to wealthy nations. The US has been falling behind as a nation, other middle-income nations, a total of 56 nations in this analysis by Steve Wolf, who's been working very hard on this issue, had higher life expectancies than the US. So, how do we respond to this as public health? We have a poor performance as a nation, which I would say is related to our poor performance with communities of color. These are not separate. And since arguably the 1950s, maybe before, public health really kind of changed its tune in response to the revolution in clinical medicine. The advent of safer surgery, the advent of antibiotics, and we started thinking we should look like them. We should focus on personal attributes. We should think about the ways in which individuals differ from others, unlike the public health of the 19th century, which campaigned on housing, water quality, and sanitation. So there was a real shift, and it was well articulated by the leaders, particularly of academic public health, that we're leaving that stuff behind. That's too broad. It's not scientific enough. We're going to focus on the individual, and we're no longer going to talk about the conditions in which people live. So the focus of public health on the social and environment really changed, and all of this was part of professionalizing public health and embracing science. And I would argue, that embracing the role of the social context is hard, but it's not unscientific. And that is why we need to think about this. And there are historians of public health and journalists. It's interesting. I don't know how many people read Ed Young during COVID. He wrote for The Atlantic. Wonderful reporting on COVID. And he argues, and others have argued, that public health had, in its effort to sort of get traction with biomedicine, had separated itself from the idea of advocacy and activism. I learned the shortcomings of this a bit personally. I don't know how many of you have heard of Marion Sims. He's viewed as the father of gynecology. He was a Southerner who developed his techniques by operating on enslaved women. He he's venerated. He had this huge statue in Central Park. His name is engraved on the mantle of the New York City Public Health Department's purpose-built building. He's venerated. And he also operated on enslaved women to perfect his surgical techniques without anesthesia and obviously without consent. I mean, he procured women from their owners to do this. So I thought we should put a plaque on his statue. This was I'm the health commissioner. I want to put a plaque on his statue or nearby, saying, he did these bad things and we should remember Betsy, Anarcha, and Lucy. And I talked to everyone about doing this that I could think of. And you might argue that it was ground softening, I don't know. But these are the women who got the job done. And they stood in front of his statue with hospital johnnies with faux blood on them. And there he is on the way to the cemetery where he now lives. And there is the statue of him that will replace, I don't think it's there yet, but that's the statue that will replace his likeness in the same location. So this is the way in which we have not been engaging, but we could consider engaging. The American Public Health Association has been tracking jurisdictions that made racism a public health crisis, and there have been over 250 of them. These declarations are still on the books. Darity and Mullen really popularized monetary reparations for African enslavement, and just last week at the UN, Ghana's proposal passed to declare the transatlantic slave trade as the gravest crime against humanity. Only votes against it were the US, Israel, and Argentina. All of Europe abstained. But still, this resolution has passed. As we seek to erase histories, I think it's important, and this is what the president of Ghana said, that he viewed this not only as a safeguard against erasure. And repertory efforts are going forward at the local level. There are over 30 efforts in state and local jurisdictions. Martin Luther King joined LBJ in talking about the need for economic justice as part of achieving equity in health. He talked about the need to realize opportunities, LBJ, and Martin Luther King, towards the end of his life, talked about the ways in which we realize that on the books, rights mean little when people last economic rights. We have seen health workers stepping out in support of their patients. We have seen students stepping out against the catastrophic cuts to science funding. We should see these movements as part of advancing public health. And with that, I thank you. Do we have questions, or apparently, I may have gone over time, I can't tell. We have 5 minutes worth of questions. We started late. Well, I've left you speechless. I do think, well, I would be curious, and maybe it will come up in the panels, about this notion of what we mean by community engagement and the burden that we place on communities by insisting that they give us time for which we often give them money. And so, the power dynamic between us is one that has to be acknowledged. And even when people get money, which is not wrong, they may not be in the position really to participate in the way we claim that they can. And so it's better to, I think, try and meet people where they are, where they can make a contribution, rather than pretend that we are equal partners when everybody knows we are not. All right, thank you.
Thank you, Mary. That gives us exactly the foundation we need. So let me ask our panelists to join us on the stage, and then I'll introduce them. Yes, that's you. A small break in our flow there. Professor Bettina Drake is the Michael Niedorf Professor of Public Health Sciences at Washington University School of Medicine and Associate Director of Community Outreach and Engagement for Siteman Cancer Center. Bettina is a cancer epidemiologist whose work sits at the intersection of community engagement and cancer inequities. Professor Marlon Bailey is a professor interim chair of Women, Gender, and Sexuality Studies and professor of African and African American Studies here at WashU. He's a Black queer theorist and critical ethnographer. His book, Butch Queens Up in Pumps, won the Alan Bray Memorial Prize, and his current project examines the impact of the HIV/AIDS epidemic on Black gay men's sexuality. Professor Karen Joint Maddox is a cardiologist at Barnes-Jewish Hospital, a professor at both the School of Medicine and the School of Public Health, and co-director of the Center for Advanced Health Services, Policy, and Economics Research. Professor Joint Maddox is a health services and health policy researcher who has published extensively in the field. Please join me in welcoming our panelists. Thank you for joining us. So let me frame where we're going with this panel. The title is Evidence and Ethics, and we chose these words carefully because the core premise is this. Public health evidence is not neutral. It never has been. It's shaped by ethical choices, by classification systems, by the questions we choose to ask, and the ones we choose not to ask, and all of this ultimately shaped by power structures. So what we want to explore in the next hour is the tension between three things: scientific rigor and ethical responsibility, measurement and meaning, evidence generation and real-world impact. I do not think that these are opposites, but they're tensions, and how we navigate them determines whether our work actually changes anything. So let me start with something foundational, and maybe Bettina, I'll start with you. So you have built your career at the intersection of epidemiology and community engagement. So let's start with a direct question. When we talk about evidence for racial health inequities, what are we actually capturing? What are we missing? And what does community engaged research surface that traditional epidemiology does not?
Thank you, Dean Galea, for that question, and a wonderful talk from Dr. Babcock, really helping to set the stage for all of these conversations. So in epidemiology, we are talking about the what and the who. It's very data-driven. We're describing the problem. With community engagement, it helps you understand the how and the why. When you actually talk to individuals who are experiencing the health outcomes that you're studying and you're trying to understand why the disparities exist or why the inequities exist in the data that we are observing. But the other thing that community engagement does is that it helps us better understand the what. How do we ask the right questions to get to the what? For example, we see a lot of rural disparities in the research that we're doing, a lot of rural inequities. But what does rural mean? And so in a lot of our research, when we talk to people that live in rural communities, their definition of what rural is could vary. And sometimes based on the HRSA standards of what geographic region is rural, that community might not necessarily see their area as rural, and vice versa. We might see an area as urban or suburban, but they really feel that those areas are rural. Also talking to those communities, if we're thinking about rural disparities versus racial disparities versus access to care, a lot of our rural areas have medically underserved, right? And so they live in areas where they have to drive sometimes a couple of hours just to see a primary care provider, even if their zip code is in a space that's not technically perceived as rural. So as we're conducting our epidemiologic research, we have to be thoughtful about not just taking our definitions and what's already in the literature and what's defined by HRSA and other governmental organizations, but actually listen to the people and figure out which of these variables do we need to be measuring, what does it mean to them? Because if we can get that right, then we can get the downstream interventions and how we're implementing those within the community right as well.
Thank you, Bettina. Karen, let me come to you for a second from the policy side. So you've done a lot of work on quality measurement, payment models, value-based care, and all of this runs on data. But data requires categories, and categories mean choices. So lead us through how the classification systems we use in health policy either illuminate or obscure racial inequities.
Yeah, thank you for that question. And I'll build on what Bettina said, which is to say that actually what Mary said too, which is to say that the data that are collected fundamentally shape what we then do, right? We sort of start by saying a system shapes measurement, and then measurement shapes the activities, the interventions that we can undertake. And I think it's important to recognize that the status quo that has built the systems in which we do our measurement goes back decades, centuries in some cases. And I work in federal policy. You know, our Medicare policy is shaped by the data that we decided to collect in the 60s when Medicare was initiated. So the race data in Medicare, which is a huge federal program that, in my opinion, ought to be a primary vehicle for reducing health inequities, is built on a system that takes race data from Social Security. So Social Security data was collected up through the 30s. There was race data in it. And back then, the question was basically black, white, other. It eventually got amended to include some other categories, but you are not allowed to be more than one category. So if you can't be more than one category, and our system started in the 30s, and were put into place in the 60s, and eventually we stopped collecting race data in Social Security. We have an entire foundation of healthcare delivery and of insurance provision and of a social safety net that is built on a status quo that is not where we are today. So Medicare is currently about 80% white. That is not what the rest of the country looks like. That's not where we're going. It's not where we're growing into. And so the measurement that we have in existence in government fails to capture the complexity that we need if we want to make change. And you can add to that, even before the federal government told us that we are not allowed to study gender, we could not study gender because gender is not captured. Sex is captured in a certain way in Social Security data. So the more layers you go into, the more you recognize that the systems on which we are building all of our evaluations are pretty fundamentally grounded in a historical system that is not where we want to be going. And we can't move forward in the ways that we want to without recognizing that the systems on which the data are built are fundamentally inadequate.
That's actually a terrific historical lesson on that. Thank you. Marlon, let me come to you. So you've done quite a bit of work to make visible communities that we have historically ignored or pathologized, like Black, gay communities, ballroom culture, lived reality of the HIV epidemic. So what happens when the evidence itself is built on exclusion? How do we produce evidence that does not erase the people it's meant to serve?
Thank you. First of all, I want to thank everyone who made this happen. Mary, your talk was just mind-blowing. It's so relevant and so important. I spend my profession as a critical ethnographer, and really, basically, my work is designed to uncover. I have an ethical responsibility to uncover systems and processes of unfairness and injustice. And part of that injustice is the way that not only communities such as Black LGBTQ communities are excluded, but how they are made invisible or rendered invisible. And part of what I think is really essential to how we need to move forward is to not only uncover those, similar to what Mary talked about, uncover those processes of unfairness, but also center the experiences and the knowledges that these communities actually produce. For me, that is, when we talk about what is evidence, that is a very important site of evidence. I'll give you an example. In 2009, I published an article in Souls called Performance as Intravention, Ballroom Culture and the Politics of HIV/AIDS in Detroit, Michigan. And what I argued is that this turn to the focus on the individual, as opposed to the cultural and the collective and the structural, is designed to reproduce inequality through the invisibilization of these very communities that are disproportionately burdened by the HIV/AIDS epidemic. But the second thing that I argued is that we need to move from intervention, which is an imposed programmatic risk reduction process, to intravention, which draws from the ways in which communities themselves do the work to solve their own problems. What they need is for the government or for the federal government to help, but get out of the way and stop being an obstacle to the knowledge that they produce and assist and enhance what they do. And so part of what I argued is that the ballroom community, which is this, at the time, kind of invisible community, clandestine community, had already created forms of risk reduction, HIV risk reduction within their community through their reconstitution of what it means to be a family, what it means to be a community, gender and sexuality, and also the ways that HIV prevention messaging and activities are embedded in the actual cultural practices of the community. So evidence then has to be, and the way to utilize knowledge production has to be centering what communities do for themselves, enhancing and encouraging and supporting and empowering communities to do the work of prevention for themselves within their communities. Thank you.
So thank you. So I think the point about erasure, if I may editorialize for a second, is worth pausing on. I've written, and I thought about this a lot, and I've used the term bearing witness. I've often felt that the role of public health science is to bear witness. But it's important to reflect what all three of you emerged said, is that the very categories, the very data that we use to bear witness often have to emerge from systems that themselves were designed to erase to begin with. So this strikes me as not a small methodological footnote. It's a foundational problem with the data that we use to bear witness, to eliminate problems that we're trying to solve, which, of course, I mean, one, I think, articulates that to the end of being clear about it, to the end of doing better about it. Let me shift to a question for all of you now, for the whole panel, if I may. So I think there's a persistent argument in public health, which certainly has been around since I've been in the field, that advocacy compromises rigor, that if you care too much about the outcome, your science suffers. And I think the three of you do a lot of work that belie this. I mean, Bettina, you run community engaged research centers funded by NCI. Karen, you've published extensively in the leading journals, but you still advise HHS. Marlon, you do critical ethnography that explicitly centers populations and communities that are marginalized. So let me have your reflections, each of you. Maybe we'll start, Marlon, with you. We'll go down that way. How do you navigate the claim or the tension that rigor, academic rigor, doing right by our mission to produce excellent science that stands the test of time, and the aspirations of a world where we achieve certain ends, including, for example, closing health gaps, our intention?
So we know that evidence is not neutral, that research on social context and structural conditions and environment is very scientific. And it is rigorous, but part of the rigor, in my view, has to include and center actually communities themselves as knowledge producers. I think the problem that as scholars sometimes we go to and work with communities and think that we are the ones that know everything and they know nothing. And we forget that they navigate their lives and they have an analysis on the conditions under which they live. So part of what I do is I am very much, before I start a research project or while I'm starting a research project, I focus on centering the lives and experiences and the narrative about their own experiences. I center that, put it in conversation with knowledge that I bring to it, put it in conversation with theories and evidence that I bring to the table, and allow for that conversation to create a new understanding of the actual conditions that I'm researching, a new understanding of the way to move forward, and a new understanding of how, for my work, HIV prevention and sexual health, how to actually address the disparities and the disproportionate impact of HIV on the communities that I work with.
I agree with everything Marlon just said, and I'll just add, whenever we're talking about community engagement, oftentimes we say, well, it takes time. It's not something that you can just walk up to a community partner and say, hey, jump on my grant or help me with this study. There are methods to the community engagement depending on how both you and that partner want to engage in that study. And so just like if you wanted to integrate a new scientific method into your grant, you would not just write it up and hope that the reviewers believe that you are qualified to do it. You would either seek out an expert in that field, you would ask them if they would be willing to participate, you would hand over that whole aim or that process of the grant to that person, right? And so similarly, if you're trying to engage partners, you need to, or if you didn't identify a person, you would actually take the time to learn the method yourself. You would educate yourself. You would do practice. You would go to seminars. You would invest the time in that. So similarly, if you're doing engagement, there is a rigor and methods to doing that, and that does take time. I think that sometimes within our scientific research, our methods can be in tension with justice downstream. So let's think about our randomized controlled trials. In epidemiology, that's kind of the gold standard type of study if we want to determine if an intervention or a treatment works. In order to do that, we have very strict eligibility criteria. So we eliminate people that have multiple comorbidities. We eliminate people, if it's a cancer study, that have had prior cancers. And oftentimes in doing that, you eliminate the very people who probably need that intervention the most. And so that raises some ethical tensions within our studies. I'm not saying RCT should never be done. I'm not saying that they're not needed, and I'm not saying that we don't need those clean eligibility criteria and standards, but I think we need to be thoughtful and aware of when we're conducting these studies of who we're excluding from those studies and what those results of those immediate RCTs mean, and how can we move faster to more pragmatic studies or secondary clinical trials that include a broader population to make sure that those interventions are effective.
I don't know if I'm allowed to push back on the premise, but
Go for it.
I guess
it's a
I think
conversation.
that research broadly has lacked a rigorous commitment to do the work to try to frame things in the appropriate lens of social justice. And I think that's an equally, if not more valid criticism of the broader biomedical community. Certainly, I won't blame public health in the same way, but certainly on the biomedical side, there has been I think, pretty stark lack of rigor around saying, if we're going to do this right, we need to think about the power structures that started this out. Who's not represented? Like, that is part of rigor. And I think we have to change the conversation to not say, oh, there's a tension between being an advocate and being rigorous, and instead say, we have to be rigorous about making sure that our work can be used to promote social justice. And if that's advocacy, that's advocacy. That's okay, I guess. But I think you can actually hold the broader community to the standard of rigor around recognizing the pieces that have to be there to do the social justice, as opposed to the other way around.
There's a super worthwhile reframing of rigor. Thank you. But Karen, let me pick a little bit on power now, because you mentioned power. So let's go into that. So, you've done federal policy work. You've seen sort of what happens when evidence meets legislative process. So what makes evidence actually move policy on topics like racial health equity? And conversely, maybe as importantly, what makes policy makers ignore such evidence?
Yeah, so not for a lack of evidence has change not occurred. I don't know that we need more evidence. I'll take my own field. We know that population attributable mortality for cardiovascular disease among Black Americans is 2 to 3-fold higher than among white Americans. This is not new. The gap stopped closing roughly the sort of early aughts. And it's not for lack of evidence that disparities exist that policy has not changed. I would argue it's not even really for lack of evidence around what works. There's plenty of evidence about the structural underpinnings of adverse health outcomes. There's been a fundamental lack of will to change the structures among the people that own the structures. And that's not the same as saying there's a fundamental collective lack of will to change the structures, but you can't change the structures if you don't own them. It's how history was written. You can look at any history book, and the people who wrote it define what we learn about history. And the people who have established the structures don't want to change the structures. But I actually don't, maybe I'm just getting cynical in the last few years, but I don't actually think that more evidence is going to make things change by itself. The evidence is necessary, but fundamentally insufficient. And I think the broader public health movement around what has to change and the tension and the difficulty of having the conversations and saying racism out loud and being able to talk about it and sort of accept the struggles of it all, like that work has to be done in order for things to change. Evidence alone is not going to change those things. It doesn't say we shouldn't create evidence, because I do believe in the importance of data to be able to put the strength behind the argument, but it is to say I think we need to think more broadly about sort of the other stuff, the harder stuff that sometimes as researchers we like to not pretend exists. It does, and it's driving politics in the world right now, and I don't know how to change those things, but I do think that we need to have the conversation about how research can pair with advocacy and broader movements if we think that things will change, because we've seen moments where it has changed. But it takes the combination of a social moment, the LBJ and Medicare and Medicaid in the 60s. What if we had made one program out of Medicare and Medicaid instead of 2? That was a political decision. It has landed us in such a different place than if we just said, everyone deserves access to healthcare. And instead we said, you deserve access to healthcare because you've worked in the system and you're old, and so we're going to pay for you. And we don't really think that you deserve it, but we know that doctors need to get paid, so we're going to give you a little bit of coverage. Like, that was a fundamentally social decision, not an evidence-driven decision. Now we've expanded Medicaid and seen that it's been one of the more disparity-reducing public actions of the last few decades, and yet now we're pushing back on Medicaid. It's not the evidence. Again, we want the evidence. We need to show why it's a bad idea to get rid of Medicaid, but fundamentally it's a broader conversation than that.
So if we're to build on what Karen said for a second, I'll go to the whole panel now and say that there are two dimensions here. One dimension is generating data, and the other dimension is, Karen, what you call the other stuff, which we may characterize perhaps as, and I've done some writing about this in the context of shifting values, shifting priorities in society. So let's talk about the university. We're sitting here in the university. What is the role? I think there's no argument. Our role as a university, we generate evidence, generate papers, generate knowledge that stands the test of time. That's part A, that's easy. So what's our role in part B? Is part B an intrinsic role of what we do in universities? Let me start with you, Marlon, come this way.
Good question. So I've been struggling with the way that we train our researchers in public health and our practitioners. And I want to pick up on this very important point that Mary laid out. This move to the individual as opposed to structural, and I would add as opposed to the cultural. It is our responsibility and what we need and how we need to change the way we train our health practitioners and our researchers to look at culture. Culture informs, not totally, but it helps inform how people think, how people consume knowledge, how people produce knowledge, how people engage knowledge. For example, focusing on the individual modification or behavioral modification does not work. In my field, I do HIV prevention and sexual health. People don't have sex by themselves, at least not the kind of sex that would make them vulnerable to HIV or STDs, etc. People don't have sex without context, without social context. So we need to train our practitioners and our researchers to think about culture. I'll just say one last thing. This is wonderful that WashU was doing this, because I was able to participate in the development of the undergraduate degree in public health and society, and why it was so important for me, at least for me, to get on that committee to help to design it, was to help to change the way we train students. We train students to think about culture as peripheral and not central. For people who live in the everyday, cultural is central. And we have to know how to read culture, how to understand culture, how it works and how it shapes people's behaviors. And therefore, the interventions that we want to approach as researchers, as practitioners, is to transform culture, transform cultures of health. And also work with people who already do that. The ballroom community already does that. And so it's also a way for us to train people how to center community knowledge, how to work with community knowledge, engage with community knowledge, and center community knowledge in the solutions.
Yeah, so the university's mission is research, education, and patient care, I think is what it has for WashU, but that's like community. And I would argue that that focus on the community, that's the context, similar to what you just said, Marlon, that's the context in which we need to do our research and our education. I do a lot of community engagement, and so it's important for me to think about the capacity building. And not just community capacity building, but also the internal capacity building of our faculty and our students. When you're partnering with anyone, you want to make sure that everyone is on a relatively level playing field with what the outcome is, a shared goal, shared vision. In order to do that, if you're working on research or you're trying to integrate community partners into educational coursework or classes, it's important that they understand what the mission is of the university or that course or that research project, and what do they need in order to level up to that understanding, but also it's our responsibility to educate ourselves on what the mission is of the community. What are they interested in? What is their driver for wanting to work with the university as well? And so, I agree. I think that community piece should be integrated across everything that we do if ultimately our goal is to improve the health of the region, of the nation as a whole.
Yeah, I realize I don't actually know the university's mission, so that's very helpful. But if we take the academy's mission more broadly, is that we are trying to drive discovery to make people's lives better, right? We are trying to make the world a better place. Maybe some people do that in a molecular biology lab and study a certain cell that causes a certain disease, and maybe some people do that in a community engaged setting, but I think it's actually intellectually dishonest to claim that we can do that without recognizing the spectrum along which health is created. And that includes the community-based work and recognitions of inequities just as much as it includes whatever's going on in a petri dish. I'm obviously not a basic scientist, with pipettes and stuff in some place. Like, these are all part of what we do to make the world a better place. I do think that it has become so political that we have had to find ways around saying that that's what we do, but our North Star is still like making the world a better place, make people better. And I don't think that necessarily has to be political. If you say, this is my goal, and these are the ways that I've identified that we have a role to play in discovery that can make people better, and the Academy's job includes that purview, then I think we should be in those spaces. And I recognize the realities of the moment in which we find ourselves, but we can't stop doing the thing. You may need to rename it if the federal government is trying to take your money away, and I get that. But you can't stop doing the thing. We're going to lose, as we were talking about, we're going to lose a generation of people who think that it is important to do the thing if we can't stop doing the thing. And so the North Star has to supersede whatever the titles are that we have to put on it right now to stay in that space.
Just to editorialize for 2 seconds, I actually, we can discuss this in a Q&A. I actually think it has to be political. I don't think it has to be partisan. I think if one defines politics as building systems and structures that determine what we as society do, I think fundamentally what we do is political. Let me move to infrastructure, because Bettina, you're in the business of building infrastructure, and that's something which I really admire about the work you do through the Confluence Collab. You've done it through NCI for a while. So what does it mean to build infrastructure to allow these things to happen? Just lead us through that, conceptually, and what are the bottlenecks to building infrastructure to support doing what we're calling Part B here, building the Karen paradigm?
Yeah, so with the community engagement, I think from partnership to partnership, it might look a little different for each group. But I think there's some core issues that when you're building the infrastructure for a community engaged partnership, there should be trust. There should be shared understanding. There should be bidirectional communication that isn't imbalanced in terms of the power. And I mentioned before capacity building. There should be an effort to build your own capacity on both sides. And so I think that's kind of the core of what community engagement in those partnerships, when you're seeking to build them, to build the infrastructure, should have. The bottlenecks, whether or not there's a bottleneck in evidence, I agree with Karen, we have a lot of evidence. I don't think that the evidence is a bottleneck. I think that evidence, we should make sure it is community informed and it's relevant to the work that we're doing. Is the bottleneck the systems? And I think that is perhaps where some of the bottlenecks may be. There are structural issues that are driven by the systems in which we work. But even still, like, you'll see systems that will implement programs that are meant to address the inequities within healthcare, but often those systems aren't sustainable. And so I would argue that the real bottleneck is on the sustainability of those interventions. We have a lot of evidence, and often what gets published in the literature are when things go well, when we reach, reductions in an outcome, or we see increases in screening. But we don't often publish in the literature when after that reduction, there's also a rise. or after we reach, an increase in screening, there's a decline. But we can see it through public health surveillance. We can see and monitor the data. And if you were to plot on there, so for example, the Show Me Healthy Women program, I don't know how many of you know that, that's the CDC program, the National Breast Cervical Cancer Early Detection, that allows women coverage for a mammogram as well as a pap smear. If we can look even in some of our local data, we'll see key places where they are implementing Show Me Healthy Women, and rates of screening go up. You'll see declines in late-stage diagnosis. And then as funding is removed, this hospital, this FQHC isn't able to continue to provide the program. And after a few years, you might see an uptick in late-stage diagnosis. You'll see a reduction in screening in those populations. And so what's so important is that when we implement these programs, we see that they're being effective, the community is behind them and supporting them. It has to be sustainable. And I know that takes resources and funding and a lot of other system level factors, but I think sustainability is probably the biggest bottleneck.
Let me shift for a second and talk about partnerships and build a little bit on what Mary said in her opening remarks about the obligation to act in partnership with communities. And I sort of feel like in a crowd like this, in person and online, I say we should partner with communities, everybody nods, that's fine. We're all sort of in agreement. And at the same time, we all realize that there's probably a spectrum of what partnership actually means. You can go from, I guess, no partnership, then there is the sort of performative partnership, often done for value signaling or because funders want it. And presumably somewhere along the spectrum, there's actually real partnership. So Martin, let me turn to you. And you're board president of a national HIV prevention organization. I think you've done work that really shows what it means when academic researchers really show up in communities. So what does genuine partnership mean? And I'd like to push you to answer that question as an academic. Like I want to push you to answer the question as, because I get this question a lot from early stage faculty. Like, your job as an academic, you're working in a university, you're not a community activist primarily, but what does it mean to be that and to really engage in partnership?
So for me, that means to, as a researcher and an advocate and activist for HIV prevention and sexual health, that means partnership means ongoing collaboration, deep, intimate collaboration with community agencies or community-based organizations to transform the culture and health conditions for the population with which the community-based organization works. So, for example, I am working on a multi-million-dollar, multi-city, multi-community-based agency to create an intervention that is designed to provide increased access to health services. It's HIV status neutral, it's gender expansive because the ballroom community is HIV neutral, meaning there are people who are living with HIV, there are people who are not, and there are people who don't know. We want to get them into services no matter what their HIV status is, and there are trans people, trans men, trans women, cis men, cis women, gays, bi, non-binary, across the spectrum. The community-based organizations work on the front lines with ballroom communities, including having ballroom communities on their staff. So what we are trying to do is to create this intervention that doesn't exist. It doesn't exist. It only, a intervention that is designed to target Black gay men only exists, it's many men, many voices, and so we're adapting this for the ballroom community. And that means that on the team, we have members, on the research team, we have members who are in the ballroom community, members on the research team who are at the community-based organizations, who will all participate in the research, who have all participated in designing the actual intervention or intervention, and will be engaged in the information dissemination, whatever form that takes. And so, to me, that's what real partnership means, that all of us have skin in the game. All of us are similarly, not synonymously, but similarly situated in relationship to not only the HIV/AIDS epidemic and its disproportionate impact on these communities, but also in relationship to the actual intervention itself. And that also means that we take culture very seriously. We take ballroom culture, a community, self-defined community. We take their ways of knowing and being and dealing with the HIV/AIDS epidemic and other sexual health issues. We take their knowledge, their practices, what they do, how they see it, we take it very seriously, and we place it at the center of our research endeavor.
Thank you. Just to the audience, I'm going to ask a couple more questions, then we'll open up questions for the audience, either in person or on Zoom. I want to ask a couple of hard questions now. So let's talk about compromise. So, Professor Mary Bassett is one of the most uncompromising people I know, and yet in her talk, there was a point where she said, well, in this political moment, well, I can live with that, which implicitly is a compromise. So I want to ask each of you, and Karen, I'm going to start with you. How do you wrap your brain around the compromises one might have to make in such a charged and divisive partisan moment, while being clear in one's own mind about what we're trying to achieve? And how do you teach yourself where to draw a line? You're welcome. Well, Bettina, you're next. So it's
I mean, that is the struggle of the moment, right? I mean, and I won't pretend to speak for anybody but myself in where that line is. I think that's pretty different for different people, and it has to be personal. And I think there's institutional versions of that decision, like what does an institution decide, and then interpersonal decisions in that space. I think at the present moment, there was an initial temptation to have individuals push back and say, no, I'm going to work on race. I'm going to work on racism. I'm going to work on XYZ, and I want my grant back. And I actually don't think that's quite fair, because you're asking an individual to push back in a space where they have no power and no ability to succeed. And you're asking an individual to give up, potentially what they work on in the name of not compromising. I think it's very different to ask an institution to not compromise and say, there's a set of activities that we believe in, that we are going to continue to do as an institution, and that we have the ability to commit to as an institution. And I think it's okay if your individual and institutional line on what that looks like have to be a little bit different. Because I worry a lot about junior faculty and students and trainees risking their future career to say, I'm not compromising on this. And I think instead thinking about what is our collective North Star forward, what are we going to continue to do, and how are we as a community going to continue moving things forward and not compromising our ultimate goals, but in the moment recognizing that people may have to change the language in their grants, or people may not be able to say what they want to say in all settings. It feels yucky, but I think it's sort of where we have landed. I hope that we can have the conversations around institutional non-compromise driven by individual non-compromise on the ethics. I don't know that we're in a position to refuse to compromise on the words right now. I wish that were the case, but I just don't think that's realistic. But I don't think we should ever compromise our ethics. And I think we should be individually and institutionally quite clear about why it is that we do what we do and what we are going to continue to move forward. I just worry about the individual burden that is going to put on young people making decisions right now?
This is a tough question, but very relevant. You know, when a lot of the terminologies came out that we couldn't say this, we couldn't do that, a lot of the grants were being eliminated, a lot of our community partners were very concerned. They were very concerned that our partnerships through research, our partnerships in education and outreach, and the screenings and information that we were providing in the community would also be eliminated. And one of the things that we kept saying, and the director of our cancer center said, that our ethos will not change. Who we are and what we do and the mission that we have will remain the same. And so I try to keep that kind of as my North Star. The core of what I'm doing is not going to change. The core of my research is not going to change. If there are terminology that needs to be changed, okay. But the work that I'm doing, the research that I'm doing will not. And I agree with Karen, I've had the same concern for trainees, junior faculty who are writing their first grants, who are looking for those first faculty appointments, and grants have been ended. And do they, at this time, pivot and do something different? I mean, I think that it is up to institutions and even senior faculty around to be a little bit more helpful, a little bit more, add a little bit more mentoring to those individuals as much as we can to help them during this time as well.
Marla.
What they said, but I'll add. I'll add. I totally agree. Let me tell you, I will change. I'll put it this way. The reason why culture is so important, because I will change the name of whatever as long as I continue to do the work. For example, 2 examples. I serve on another board for a trans organization. And, you know, when the drama came up, we had to work with the executive director about changing the name because trans was in the name. And this impacted funding, right? So in some ways it impacted funding because some funders, particularly the county funders, took the funding away. And this is a small community-based organization in the Midwest, took $250,000 away from them immediately. But there were other organizations that did not, there are other funders that did not want them to change their name. Foundations did not want us to change the name. So and community did not want us to change the name. So what we came up with is we changed the name. We were, useful and creative with the language, but communicated that we were still our mission for the organization to provide services for trans communities, non-binary communities, et cetera, did not change. Similar with a grant. We can change because culture is very useful to come up with different kinds of language, change the name, but we are still doing the work, as my colleagues here have said. And that's really what is most important, is that we continue, and I don't compromise on the work. I refuse to compromise on that. I can change the name to some stuff, but I'm not compromising on the work that I'm doing.
One last question, then we're opening up to audience, because I know we already have a bunch of Zoom questions. So we'll go this way, Marlon. A doctoral student today, 2026, comes to you and says, I'm leaning in, I want to do a PhD, and I want to spend my career studying racial inequities. What do you say to them?
Come work with me. No, I'll be honest about the challenges, right? It's my ethical responsibility to talk about the challenges. But I have to say that when somebody wants to do this work, they want to do this work because they believe that they were put on earth to do this work. And I'm not going to discourage them from doing the work that they felt or they feel that they were put on earth to do. Like me, I feel I was put on earth to do this work, and no one could discourage me from that. And I would not want anyone to discourage me. I would want one to support me. Give me the information, but say, hey, go do it. Go do it, and I will support you in doing it in whatever way that I can.
What he said, no. But absolutely, yes. That is the work that I do, right? And so if a student wants to get their PhD or want to be a postdoc and continue to focus on racial inequities, yes, it's important, regardless of what the current policies are. That does not change that there are needs that need to be addressed here locally and nationally. So absolutely, I would be there to help them.
Yeah, literally just what they said.
Okay, I'm opening it up to questions from the audience. I'm going to start from Zoom, because please line up here, but I'll start with a Zoom question, and we'll take the question here. The first question, Karen, I'm going to go for you. So the questioner says, I agree with Dr. Joint Maddox that sometimes it seems like evidence matters less than it used to forming policy, and the other stuff, what we call category B here, is mattering more. And the person notes, this is the toughest time to the policy ever. But I would argue that the other stuff will become less of a roadblock at some point. And as a result, our responsibility to continue generating evidence remains as important as ever. And the person would like to know your reflections to that.
What they said. No, I completely agree. And, I think if we could create the infrastructure to bake it into the norms that federal policy must consider race, must consider poverty, must consider the ways in which those things intersect, and create the accountability to make things, that is the job of the federal government. It is to ensure that everyone has the ability to pursue life, liberty, and happiness. I said that completely wrong. But what the founder said, there is a fundamental responsibility collectively to make sure that people have the opportunity to reach their best possible health. And whatever you call it, if you want to make that happen, you have to understand the inequities underneath it. And so I hope that we can build toward a new moment in time in which we can have those conversations across all of these different identities and intersections and whatever that looks like, and say that collectively we are responsible for us collectively, and that should be baked into the responsibility of what we expect that the federal government will do for us and should be part of policymaking. I hope we get there, and I agree with the questioner.
Thank you. We'll take one question here, one question there, and then we'll go back to Zoom. Let's go over here. Sorry, I can't really see you with the podium.
Hi, my name is Caitlin Reedy-Roger. I am the faculty who teaches health equity and justice at the med school. And one of the things that we have encountered as one of the challenges among many in this current political climate is actually the identity. So me being a white person teaching that, and my co-director being a woman of color but of Indian descent. And so I'm curious how you all navigate your own personal, in particular as we think about race, your own personal identities in the work that you do, and who is the right messenger, and how that message is always interpreted through the lens of race, and who is delivering that.
That's a great question. Maybe all three of you. Marlon, why don't you start? We'll go down that way. Go.
For me, I make it very clear about who I am, and that informs, I let people know where I'm situated in relationship to my work, in relationship to structure. And so for me, it's a really important methodological approach to situate myself in relationship to the work that I'm doing, and including what I'm teaching. So it's really important, and it also, in terms of my research, it also helps me connect, because I do research on clandestine communities, people who are underground, and knowing that I have a similar experience, I have a similar relationship to HIV, for example, it's helpful for me to build trust and to be able to do work on their behalf, with them on their behalf. Can I say something real quick about the previous question? I think it's important for us to reconsider what evidence is and be more creative. The problem that we have is that the way that we do our work, we do the same things over and over again, and we do not include creativity. What would it be like to allow for a novel, a piece of fiction that really has a perspective on reality to guide some of our work so that we can think outside of the box? The problems that we have, one of the problems that we have is a lack of creativity and the lack of training people to think creatively about these problems. Thank you.
I don't think that there are any issues with people of different racial, ethnic backgrounds teaching students on the impact of racial inequalities in our society. I don't think if you're talking about disparities among African Americans that it necessarily needs to have an African American instructor. I think that it's helpful when the instructor can kind of position or describe what their background is and how and why they're coming at a problem, why it's important to them, why it's something that they're interested in. I think that's helpful for students. I will also say that for community engagement, I do a lot of research in prostate cancer. I was working with a community partner and I wanted to do some focus groups among African American men to understand screening patterns and kind of what drives them for screening. And my community partner was like, I know your intent and I think that it's great. He said, but if you're going to do a focus group, I don't think you need to be the one to lead that focus group. If you're going to be talking to 50 and 60-year-old African American men, they probably don't want to look at someone who looks like, their daughter or, another family member. And so I think there are times in our research or probably even in education where we need to listen to that. And if there are sensitive questions or issues where you want people to be more open and to feel more comfortable, then there is value in having people in front of you that look like you and may have similar experiences as you.
I'd agree. I think it's fundamentally about recognizing that the broader issues are collective and about partnership, and just knowing that we all do bring what we bring to the table, and we've all decided to be here for various reasons, and acknowledging what you do and don't know. I don't know the lived experience of being Black in the US. I will never know that. And I shouldn't pretend that I know that. I still want to show up and try to reduce racial disparities in our country, because I think it's a scourge on our country. But I'm not qualified to make certain statements about what that means. And I think that's all okay, as long as we're sort of honest about what that means and how we use terminology and try to show up for each other. But it's not easy, and it's not always comfortable. And I think I certainly have done it wrong. And probably will continue to. And so it does require a certain amount of just belief in the collective, that even when individuals do it right or wrong, if we're sort of collectively recognizing that the more people that are driving toward a North Star, the better off we are, and figuring out how to have those conversations is actually really important.
Thank you. That was a terrific question and really, really excellent answers. Over here.
Hi. So, Leopoldo Cavazza, I'm a professor here at the Brown School of Social Work. And I do want to push back a little bit on the discussion about the words. And I'm deeply concerned about the attitude of some of our colleagues are saying, like, we can, let's do away with those words, change the words. Words matter. And the federal government is not only raising words, they're raising people and communities. So I think we need to pay a close attention of that component. It's not just about a grant. It's about the science, the people behind it, and the communities behind it. And in governments like this, words, the line keeps shifting. Personally, I've seen it how it's been destroyed, words in a particular grant, but now it's not only the grant anymore, it's the people behind those grants, the investigators, the trainees. And I'm concerned about another component. So two comments to that. One is that institutions are made out of people, Institutions are not this amalgam or things. So the choices that institutions make are choices that people are making. And in academia right now, particularly here at WashU, we've made this decision, the institution made the decision to leave this to the individual to deal with it, rather than to the larger component. So I'm deeply concerned about that and your reaction. And to your point of culture, I think it's super important because words develop culture, culture inform words, actions and choices are about that. And what we do actually matters in that sense. So reactions on that, and I know this has been a strong, that I'm still struggling with that with trainees and others, but I think we need to be very careful about just erasing different words and not doing that. We have to pay attention to that because those words are people as well.
That was a really nice question that gets at the question I asked earlier about compromise and where is your line of compromise. Marlene, would you like to tackle that?
Yeah, you're exactly right. And it's a difficult question. I think it's case by case. And words have multiple meanings. And that's the beauty of language. And I think that when you have to make a choice about, this whole situation is just total crazy. I mean, it's bullshit. This is ridiculous. It's infuriating that my team and we had to go to our grant proposal and do a MAGA washing of the grant. And it was infuriating. It was debilitating. It was really horrific because I knew exactly what you're saying. However, what we decide is that the most important thing is that we do the best we can to get this grant because the services, because we're going to do our work, right? No matter what we say in the grant, we're going to do our work. And the most important thing is to make sure that our communities get access to these life and death services. But your point is very well taken, and you're exactly right.
Go ahead, Bettina.
I was just going to add that I do agree that those are some individual decisions, and it is a compromise. It's not ideal in any way. And I guess in my optimistic mind, I feel like it's limited. I'm hopeful that this is time limited. I think hopefully what we're also doing is taking account of the shifts that we're all making so that we don't have to start from zero whenever this period in time is no longer. Maybe I shouldn't be hopeful of that, but I am hopeful that this is for a short period of time, but that if we continue the work, we will be able to go back to that. But it's not ideal, and it is, I think, a choice and compromise.
So I'm going to take one last question from Zoom, which actually I think builds very nicely on this question, because the question from Zoom, which came in before your question, but I think it dovetails nicely. Well, how does one effectively work with colleagues whose line of compromise is different than yours? How does one work with colleagues who, I think Karen said something really, really incisive earlier when you said, ultimately it's a personal choice, and I was actually going to use that in my question. But fundamentally, you're working with people, and other humans may have a very different line of compromise than you. So how do you figure out how to work with people's line of compromise, maybe more or less than you? Maybe Karen, I'll ask you to start, and we'll go this way, and then we'll close.
I guess I think that the work right now is trying to find the underlying common ground on which people don't feel the need to compromise. So our center has done a lot of work with the state. I've done a lot of work with the federal government. I could continue to do a lot of work with the federal government. And we have this sort of unwritten understanding to operate under the line of politics and talk about what is it where programmatically we're trying to move something forward. And fighting with those people that I'm working with, who I consider colleagues, about what we're going to call something is ultimately less useful than saying, okay, and I work in Medicare payment policy, so we want to move this forward because we think it will make people's lives better. And if that's what you're saying, you're fundamentally meaning you're going to reduce disparities, because the people who have the worst health outcomes are the people who these programs are designed for. We're having the same conversation. But they have a very different line of, they can't use any words. I can use whatever I want as a private citizen. But it is, I think, about finding the underlying sort of humanity in the discussions around what we're moving forward. And with our state colleagues, I don't do community engaged work, so when I think about the communities that I work with and try to have these conversations, it's largely policymakers, either at the state or federal level. And the vast, vast majority of the people that I have worked with want to do the work. It is a very small sliver of the ecosystem out there that is controlling the narrative. It is not actually the norm among humans here in this society that they want to be divisive and want to make compromise and want to be controversial. People want to show up and do the work. So I guess at least for the policymaking work, it's to figure out how to have the conversation about the thing that we want to move forward and not have the conversation to argue about the controversy right now.
Bettina.
I think you're right. In academia, we collaborate with people all the time. I don't think it's new to have to work with people who disagree with you. I think, often we have to collaborate with individuals who we don't 100% agree with. And I think perhaps you should take a similar approach. In terms of this question about words and specific words where we aren't able to use them anymore, I have to thank, you, Sandro, and Dwight for having this race, reason, and health place where we can talk about race, we can talk about inequities, we can say the word racism, and I think finding places like that and partnerships like that, if you're struggling to do that, is probably would be my recommendation.
What they said. That's tough. I just need to be honest. So it's really hard. It's really hard, and it's a challenge when you are working with someone who has a different line of compromise. And so I really focus on trying to find people who share my objectives, because at the end of the day, we ain't got time for all of that. People dying. We ain't got time to be debating about that. People dying, right? So let's deal with it. So that's how I usually approach it.
All right, last question, very quick round. When Professor Bassett was speaking, Mary said something that really stuck with me. He said, well, since the beginning of the Republic, even before being a Republic, there has never been a time when Black Americans have lived lives that are as healthy and as long as non-Black Americans. And when you hear something like that, I sort of knew that, but I never heard anybody say it that way. I think it's easy to get despondent. So my last question quickly is hope. We're sitting here, 2026, in a time when actually a lot of the words that we've been using today, in theory, we cannot use in particular circles, grand circles. So one could see that as a moment of peak despondency, or we can lean into hope. What gives you hope?
This, and other fora like this is what gives me hope, and also communities. They don't have the option of not hoping, right? They don't have that option. So that gives me hope.
Same. I was going to say spaces like this, where we can continue to do the work, we can continue to talk about the problem. The fact that the university is also still very committed to community engagement and a focus on what we are doing in order to improve the health of the people in our region by bringing them in and collaborating with them and addressing the needs gives me hope.
Can I say the midterm elections?
Yes, you can say anything you like. It is your space.
Yeah, right. What they said, but also I think the moment in time has made a lot of people have to sharpen their commitment to stuff, right? This is challenging. And it felt like there was a weird ripple for a while, and maybe this is just my optimism, but it feels like we're like on the other side of a ripple, and now there's like sort of a renewed commitment among a growing coalition, I think, to say, oh no, we're still doing the work, and it feels more sustainable, I think, to be in these spaces than it did a year ago. And I hope I'm reading that right. I hope that's not just fatigue or something, but I feel collectively that there is an idea that there is resistance, and that there was a path on which we were trying to put ourselves collectively, that we are continuing to try to put ourselves on, and that fundamentally hasn't changed.
Please join me in thanking Professors Drake, Bailey, and Joint Matter. Thank you to our outstanding panelists and to Professor Bassett. We're going to take a break. We'll reconvene at 11:30 Central for those who are on Zoom. Thank you.
We're now ready to begin the second session of the morning. It's my pleasure to introduce Dr. Dwight McBride to the stage again, who will be moderating this panel. Dr. McBride is the Executive Director of the Center for the Study of Race, Ethnicity, and Equity, and Senior Advisor to the Chancellor at Washington University. A distinguished scholar of race, identity, and higher education, his work focuses on advancing equity in academic and public institutions. Handing it over to you.
Thank you, Courtney, and thank you all. And delighted for those of you who are sticking with us through the second session. I want to also encourage folks online as we start the session to, as questions develop for you, by all means, feel free to submit those at any point. We'll hopefully have time for those at the end as well. We have three remarkable panelists with us today, and I want to briefly introduce them in the order in which they appear on the program. First is Sierra C.J. Walker, and is the founding CEO of the Community Health Worker Coalition here in St. Louis, a Howard University alum and an Emory MPH alum. CJ has built the coalition into a statewide social enterprise that has also served as a national model. Serving as Vice President of the Community Health Worker Association of Missouri, she is currently completing her doctorate in public health leadership at the University of Illinois at Chicago, and is the 2025 recipient of the Missouri Foundation for Health's Spark Prize, a $200,000 award by which the foundation recognizes individuals who work to improve the health of Missourians. Welcome, CJ. Our next panelist is Rodrigo Reis, and he is a professor of public health at Washington University in St. Louis, affiliated with the People, Health, and Place Research Unit and the Prevention Research Center. He is an internationally recognized scholar whose research centers on physical activity, urban health, built environments, health equity, and place-based interventions. He's authored over 230 peer-reviewed publications and contributions to major global health initiatives. Welcome, Professor Reis. Our last speaker will be Rakaya Yerby, who is the Judge Clifford Scott Green Chair in Law at Temple University, and a member of the Center for Public Health Law Research. She is an interdisciplinary legal and public health scholar whose work focuses on structural discrimination and the social determinants of health, and is co-founder of both the Institute for Healing Justice and Equity at St. Louis University and the Collaborative for Anti-Racism and Equity. Welcome, Rakaya. So we are thrilled to have all of you with us. We're going to dive right in. This morning's keynote and the first panel have made it clear what the evidence shows, and that is that racial health inequities are not the product of biology, individual choice, or cultural deficiency. They are the product of policy, decisions about where resources go, how systems are built, and who gets counted and who gets left out. And yet, there's a gap, often a very wide one, between naming the truth, naming that truth and changing it. Research produces findings, policies get written, but communities are still navigating systems that were not designed with them in mind, and often were designed against them. What this panel brings together are three people who operate at different but connected points of that chain. Professor Yerby works at the intersection of law and public health, examining the legal structures that either entrench or dismantle structural racism. Professor Race works on the built environment and physical conditions that shape whether people in a community can actually be healthy, the places, the infrastructure, the design of neighborhoods. And CJ Walker, although we should call her professor as well, given all of the incredible work she does, and she does teach us on a regular basis, works inside communities themselves, building the workforce infrastructure, the trust, and the institutions that let people navigate systems and exercise power within them. Together, they represent something like an integrated theory of change for racial health equity, one that operates at the level of law, place, and people simultaneously. I want to explore with them what it actually takes to close the gap between research, policy, and community reality, and what gets lost when those pieces don't, in fact, talk to each other. So we'll start with a framing question for the full panel, and that is, the framing that this morning has made clear is that structural racism is a root cause of health inequality. But I want to ask each of you, when you're actually doing your work in government agencies, in neighborhoods, or in community organization, in a policy table, what does structural racism look like up close? And what are you actually fighting in those moments, in the work that you do? And we'll start maybe with you, Professor Yerby.
I just want to take an opportunity to thank you, to thank the Dean, Dr. Bassett, for having me, and I'm so excited to be a part of this panel. So how it shows up for me is the failure to tell the truth. That when we think about the historical happenings of discrimination, that we never got rid of them. And a lot of what we are doing right now is just a reproduction of the failure to be honest and to really repair the harm that we have done. And so I'm just gonna pull a line from where you started, Dr. Bassett, of talking about Title VI of the Civil Rights Act, which prohibited racial discrimination. And that, along with Medicare and Medicaid, was used to supposedly racially segregate hospitals, but it never was. That's the story we're told. But a government report, a federal government report that went to southern states a year later actually tracked hospitals in those southern states that still refused to desegregate, but still received the money. Furthermore, it was a choice by the federal government, the U.S. Department of Health and Human Services, never to require physicians to stop racially discriminating. Yet somehow in 2003, when we had the Institutes of Medicine's report about physician bias, it shifted to implicit bias, but we never required physicians. Hear me when I say, we have never required physicians not to discriminate by race. We have never required physicians not to discriminate based on gender, based on sexual orientation. There is no requirement because HHS decided that Title VI did not apply to physicians. And so when I'm in these spaces and we're talking about it, people don't want to acknowledge that we have never actually truly been committed to equality. The last thing I will say is that it's great that Lyndon B. Johnson passed Title VI. But in the passage of Title VI in discussions with Congress, he specifically said we are not going to apply it and desegregate in nursing homes the same way we will do in hospitals, because nursing homes are viewed as people's homes. And so we are living in 2026 at a time where we never really were fully committed. And so when we talk about not saying the words, there's so much more that we need to do, but what we need to be clear about is, what do we mean by equality? And to me, equality means that everybody gets what they need. Not everybody gets the same thing, because that would be stupid, right? If you have somebody who has a peanut allergy, are you going to feed everybody peanuts? No. So when we talk about structural racism, when we have to tell the truth that we have never actually worked to accomplishing equality, and we have to be clear about what equality means. And so when I'm in these spaces with governments, I say that. I might say it a little differently than I do at my university, and at my former university, where I didn't say it differently at all. I would just say, we are not doing what we are supposed to. And so when I walk in the spaces as a lawyer, I say, no, by law, we are required to do this. And so let me tell you what we are going to do, which is to be honest about the ways we continue to discriminate against so many various people, and then talk about how we can fix it.
Thank you for that. Wow. CJ, how does this show up for you in your work?
So I will be honest and share some of my experiences. I'll start just by echoing in the thanks for having me here today. My goal in today's discussion is to really humanize how we hear this conversation. I think the word structural automatically creates a level of dissonance, and it makes it feel like it's a distant problem, when indeed it's very immediate and happening now. I also think that we tend to use the word community as if it's interchangeable, when we recognize that communities look very different. Each of us are actually a part of a community. It might be a very different community, but we belong to one nonetheless. One example that I'll give is, you all may have even seen this video circulating the internet. There was a white woman researcher who was giving a TED Talk, and abruptly in the middle of her TED Talk, she asked a very bold question specialized to her white counterparts. And she said, to all of my white counterparts in the room, I ask that you stand up if you'd like to take the position of one of your Black peers who are sitting next to you in the society today. The room not only went quiet, no one stood up. So that's what I'm fighting. I'm fighting strained racial relations and invisibility that has been treated as neutral. I'm fighting the opportunity for people to position themselves in power when that place actually doesn't exist. I'll give a very real example that Dr. Bassett actually illuminated to me in the talk, which is, we do have to call out racism intentionally, but it has to go beyond our academic peer journals. And I think that that's what you were alluding to, Professor Yerby, where we have to start to have these discussions in the places where decisions are made, and particularly where budgets are curated, because resource is what drives change. I recall, transformation, in my opinion, begins from the inside. So I really appreciate the theory of inside out. And as I look at COVID-19 as an example, it wasn't that we created a new system in order to fix those challenges. It's actually that we began to pass the mic to treat lived experience not only as expertise, but as evidence to the things that we were experiencing. And that is exactly how we should continue to do our work. And today, COVID-19 was not a failed system. It was old architecture that we still leverage today. So I will ultimately just say that through that research, there were three fundamental things that were elevated. One is that sustained transformation starts at the neighborhood level. Transformation can occur anywhere, but sustained transformation starts at the neighborhood level. The second reality is that we must support and resource Black leaders, especially Black women. History shows us exactly how Black women show up in the fight of change. And finally, we have to trust lived experience, not only as evidence, but as expertise, particularly when we are making decisions.
Thank you for that. Yes, yes. Professor Race.
1, 2. So before, well, thank you so much. That was really touching and profound. So a quick preamble before I answer your question. First, I want to acknowledge, no, this is happening at the heart of the Black Lives Matter movement, St. Louis, and unfolding of the tragic events here originating in CRE2, for instance, and many initiatives at WashU. So it's not a sort of a random conversation. No, we are talking about things that matter, where things happen. And no, a lot of the narrative today is generated after that. So I think it's important to acknowledge that. Second, I spent most of my life identifying myself as a white man, heterosexual white man. And when I transplanted myself to St. Louis 10 years ago, I found out I'm a mixed race person because, that's the identity I have been recognized. So my comment is, no, I think if I would change something for the seminar, I would put identity as part of the title. It's very hard for me to separate race and identity because, we have identities built up on race that we carry or we accumulate over life. So I'll talk about that in a second. So please understand my biases when I say whatever I'm going to say here, they come with that background. It's very important for me to say that. And third, but not least, I have been studying, cities across the globe. So my work, I would define as global to local, some people say, and studying how cities can be better designed, more equitable, and healthier for everybody. So my angle goes on that, with those three lenses. So please understand that. And I always thought I would never be able to talk about race in an open forum, but I will share with you my thinking about that. So thank you. So answer your question, I think it manifests in three elements. First, a space. And the space I will largely define as the physical boundaries where we live. And it manifests on who owns the land. And you go from redlining in St. Louis or favelas in Brazil. And this is the same history across the globe, particularly for the Western Hemisphere and the Americas that suffered the tragedy of the Western Africa diaspora from and slavery. It's the same story. Who owns the land? From native populations in those countries, some people call them brown populations, but we'll call them native populations, to what we call now black populations. Who owns the land? In favelas in Brazil or in North St. Louis, that's the one issue never solved. In the United States, all land has been privatized basically from the get-go, right? In the pre-colonial stages in Americas and during the colonial stages, all the land was owned by the crowns, Spaniards or Portuguese crowns. And when they left, there was a lot of vacant land that nobody was claiming possession. And the US was privatized. And the rest of the colonial, pre-colonial, and post-colonial Americas was no unclaimed land. And unclaimed land was possessed by who possessed the arms. So that's the first one. So you see who owns the land, you see where the issues are across the globe. And who has a say on land ownership. That's the one thing. To me, that's the root cause of many of the inequities for space. The second point I want to make is place. So I would define place where the manifestation, the physical manifestation where we actually feel that we belong to and where identities are formed, from churches to community organizations. And so space and place are not the same thing. You can have the land, but if you don't have a place where you feel you belong to, you don't have identity. So there are classical examples of that. Housing projects, they relocate people to other places. They go back to the other place they were, because not all of them, but because they feel they don't belong where they were transplanted. So giving space is not enough to feel a person belongs there. And if you think through history, bringing down places is how we erase identities. It's happening right now. But if you go back to World War II, the backlash from Reinhard assassination in Czech Republic. So what the Nazis did, they went to Lice and they just dismantled the whole village because they didn't want people to feel identity to the space. And that's the same tactics we use today. For fast forward, I'll get to the end. Fast forward, post-tornado in St. Louis, we had a tornado here. We all know the history. And we are doing some work to try to understand how we can mitigate some of the damage. Some people could not afford to stay where the tornado was most impactful, and they have been removed for places they can afford to live. So they have been transplanted to spaces where they don't belong anymore. So the question is how we can build identity for people that are being moved to those places. So you see what happened in post-Nazi Germany, in Nazi Germany, and what happened in post-tornado to me is the same thing. If you don't have a place, you don't belong. And how you have identity? If you don't have identity, who are you as a human? So that's the second element. And the third element is the health component, based, improving health inequities through place-based interventions. It's not only about putting resources where people need, it's actually putting resources for people to have ownership about how the resources are delivered. So we have been more or less better at putting resources when people need, more or less, because there's tremendous failures we saw in the lecture today. But there's very little examples of giving people ownership on the resources they need to live on. So that's my spiel.
Thank you so much. Professor Yuri, I want to go back to you for a moment. Your work has focused very clearly on why anti-discrimination law has not been sufficient and why even well-intentioned legal frameworks often fail in producing health equity. What's missing from legal and policy architecture, and what would a more adequate framework, what might it look like in practice?
Yeah, so I would say not just anti-discrimination, but public health as well. And so there was a wonderful article by Professor Angela Harris and Aisha Pagmunchu from Change Lab of talking about sort of this new civil rights movement of connecting sort of the best of civil rights with public health law, right? And what actually I'm working on a grant with Robert Wood Johnson Foundation right now to do that for public health law professionals. And so what I say is needed is anti-discrimination law is traditionally individually focused. That's not always the case, but it is usually focused on an individual harm, an individual claim. The good part about population health and public health is that we have population level, right? And so we can think about what could be the impacts of a broader community. And so what I tried to do in my revised social determinants of health model was to bring in the best of both, of including root causes, right? So including that discrimination is a root cause of poor health outcomes, that law is a tool for creating these poor health outcomes, but even to go further, right? And I know you might ask this follow-up question, but I'm going to answer it before you ask it. Oftentimes, the people in power tell us that anti-discrimination law cannot be used to change structures, right? But what did Students for Fair Admissions do? It changed our entire structure. And so that is what I have always been saying, but now I say it explicitly. Students for Fair Admission was only about undergraduate admissions. And to be clear, it was only about Harvard and UNC's undergraduate decisions, because every school is different. But what has it been used for? To change our whole society. And so if they can use anti-discrimination law to change structures in harmful ways, then we can harness that power. And so in my frameworks, I talk about if we could use one case to change how we talk, then we can use that case to change how we do it for good, right? We can change that to change what equality means. We can use that to change education, to change access to employment. right? And so that's what we need to think about in our frameworks, is that what we're told and what we do can be different, because we're always told we can't. And what we should be doing is saying, what can we do? Right? And particularly at this time when people are using destructive ways, how can we reimagine what they are using to better support people? And so that's what I do when I work with governmental agencies and when I talk to public health people, saying that yes, we have the tools to use law in an effective way, because they're not abiding by the laws, but we can redefine them in ways that support and help people. And as you saw, I just did, because there's nowhere in the law that specifically says that equality is only giving everybody the same things. Right? And I'll wrap up by saying, when you go through the historical documents of Jim Crow, they used equality and equity interchangeable. And so the fact that they claim we can't say equity, I'm not listening to them, because I've read the laws. And when separate and equal was being used, and they talked about Hill Burton hospitals that were not providing care to Black people, they said as long as it was equitable. And so I use that then to say, well, if equity meant equality then, that it means it now.
Amen. CJ, I want to turn to you briefly. I mean, you have actually co-authored policy frameworks at the state and federal level. And does what Professor Yerby is describing, does that square with, I saw you nodding a lot, but square with your experience in trying to get policy to move?
Yeah, I would say completely. I think one of the ultimate goals that we all have in common here is that we have a desire to restore humanity in a way that creates a thriving global economy. And that can only be done when we do things like what Professor Yerby just mentioned. I would add on to what she said by saying, as a non-lawyer, it's important for us to right-size who we consider to be knowledge producers. It has been so common that policy is often only considered to be done to people and not to be produced with people. I think from my experience, what I've realized is that the policy that is actually the most effective is the ones that are co-created with those who are the closest to the problem. And by co-created, I don't mean in a consultant or a beneficiary way. I mean a true co-owner. I also know that sometimes the legal infrastructure or the policy infrastructure can fail simply because not the gap in law, but the gap in legitimacy. Who's actually trusted and who's actually listened to. So as you may sit in the room similar to me and not be a lawyer, I have a couple of tools that I just like to share that move policy quicker and allow us to actually get involved, demystifying some of the fear that might be around such a sticky topic. One of those tools is called the collaboration continuum. Whether we believe it or not, we all start in a space of competition. And then it takes us gradually and intentionally moving ourselves through a continuum to reach true collaboration. That continuum looks like competition, and then networking, then cooperation, and then partnership, then collaboration. And that's a evidence-based tool from the Teagle Foundation that you can look up. And one that has informed my organization as we developed our theory of change has been the two-loop model. The two-loop model is all around dismantling the dominant system as a new emergent and innovative system is rising concurrently. So those two tools are ones that we can employ as not only practitioners, but as legal professors or professors in general, so that we demystify what it looks like to engage in both policy and law.
Thank you for that. Yes. Yeah. Of course. Yeah, absolutely.
I just want to say that is so great. And I want to highlight it again. You said dismantling. We don't have to do the work of dismantling. We could build, right? So we don't have to do the work of dismantling. We could build. And that's what we need to be doing. Great.
I want to stick with this theme of building and talk a bit about environment. And I want to start with a question both for CJ and for Professor Race. CJ, the organization that you lead is built on the principle, and you referenced it just now, that I find compelling and really, in some ways, quite radical. And that is, and I quote you, "Those closest to the pain should also be closest to the power." right? In practice, in terms of workforce governance, intellectual property, economic ownership, what does that actually mean, and what has it taken to build institutions that reflect it? And similarly to Professor Race, as a follow-on to that, your work on place-based interventions raises related questions. What does it mean to design built environments with community power in mind? And this references, in some ways, what Marlon Bailey was saying on the last panel, right? The importance of culture and centering community, et cetera. So I'll leave that with the two of you.
Well, I'll share that sometimes when you hear phrases that have an alliteration to it, it feels decorative, but I actually mean what you just heard. And one of the things that has allowed me to really lean into it is by decentering myself for those that we claim to want to support. And while I might be a representative or a member of that very neighborhood, all experiences are not the same. One of the things that I've realized is that transformation only occurs when something changes. My grandfather says, nothing changes if nothing changes. And it feels like a super simple term, but it's actually pretty dense. What it looks like in practice for us is handing over power in a way that feels tangible, not just resource, but also the opportunity to do power building. So you may have heard a phrase that says, I'm the voice of the voiceless. It's a phrase you'll never hear me say because I actually believe in passing the mic. And what occurs is we have to build up the voice of the voiceless so that when the mic is prepared to be passed, they are prepared to take it. I also recognize that governance is where a lot of decisions are made, whether we acknowledge it or not. So bringing neighborhood leaders into the space of governance so that they don't have to sit at a table that was already built, but can instead help to build the table that they will participate in has been extremely helpful. Finally, I'd say that, when knowledge is produced, that ownership often gets lost. And what we can do, not only as practitioners, but people of positional power, is to ensure that it stays rooted. That's in terms of narrative advocacy, that's in terms of economic power, that's in terms of decision making. So the way in which we at the coalition have been able to do this is to recognize that every single CHW we represent has an individual story. And as we begin to pursue their individual stories, we create or co-create a reality that acknowledges and respects it. So there's the idea of reciprocal respect, an idea of adaptive leadership, an idea of building from the inside out that allows us to do this work in a way that not only feels respectful, but feels sustainable. Now, I'm sitting here saying it very eloquently, but it has been hard. It is a very difficult task, not only for the natural resistance, but we have to understand that many of us have gone through challenges that have caused us to lose our voice in some circumstances. And I truly believe the quickest way to lose power is to believe you don't have any. So we continue to sit in the reality that transform people, transform systems. So instead of me looking to transform a system that is actually obsolete and inanimate, my goal is to make sure those who represent that system have an opportunity for freedom and liberation.
I told y'all were in for a fabulous panel today, yeah.
I think can I just go to the audience? I think that's a very good question. I think there are two elements to keep in mind, and this is on my angle as been doing this for 20 years in cities and seeing experience and being part of either on the academic or on the policy decision part a little. I was never engaged as a community builder. So I was never, I have been personally an advocate, but I was never in community building communities. So there's a bias on my answer because I don't have that experience. Besides my experience as a human living this planet and searching for the same things. So what I see the struggle with two elements. One is scale. So what are the solutions we can take to scale? And there are a few solutions. In the US, there are a few solutions. In Boston, there's one land trust that is community driven. Then in Washington, D.C., there's another one. There's another one in California, which communities are building wealth to buy the land back and to build the communities the way they design. So that's one angle. It's developing resources and mechanisms to, from the ground up, decide what you do with the land that you have. So there are examples of that. It's not scaled up, but there's potential for scalability. But because cities are not the same, and cities are very hard to compare, because the governance system is very different. Not only the administration structure, but the culture of governing is different. So the way you decide things in St. Louis City or in the county or in Boston, the traditions of deciding on things, it's very different. So to me, governance is built on that structure and traditions. So in other places where you don't have the tradition of doing that, there are other solutions that have been developed. For instance, in Bogota, bike advocates in the 1980s, they decided to advocate for more bike lanes. One crazy wild mayor was a bike advocate, decided to help them. Fast forward almost 30 years now they have 1 million people using bike lanes every weekend. That's the Ciclovia Bogota that has been expanded across the Americas. But it's another example where there's not one single solution. Another example we did, when we did in Brazil long ago, we helped understanding community-based interventions that were developed by communities in a few cities. They had physical activity classes in parks. They were reclaiming for their use. We developed the evidence for that. They have been scaled up for a nationwide program that is based on an initiative that the communities developed. So to the issue of scalability, I think we should be looking to different types of solutions for different governance systems. I don't think it should be on the ground up the same way. Sometimes we start at the intermediate level, sometimes on the top down. That doesn't mean it doesn't work. So we should look for different solutions for the scalability part. I think that's one. The other issue, I think, it's even more challenging, and we heard that in the lecture today, is sustained change. So, and why that has been hard in my experience in the projects I do, when you change the governance, when we change the politics, or the social norm is affected, it could be the pandemic, for instance, or it could be somebody else is elected. That shakes the governance very hard. And one of the first things that go away is resources for those sustained changes. So I don't have a good recommendation on that, because that's the issue that my colleagues and I have been asking across cities, and not only what is scalable or what is sustained over time. And I think for that answer, I'll leave that in blank, because we are searching for that yet.
Thank you for that. Thank you. And you actually raised a question, I think, that segues nicely into what I want to use to conclude at least the moderated portion of our time. And then we're going to open up for questions from the audience and from Zoom. And that is about translation itself. So I specifically the translation between research and action, right? All of you, in different ways, as you've beautifully recognized, work at that intersection to different degrees, right? All of you have had incredible academic experience. All of you have done measure of work in communities with government agencies doing policy, et cetera. What gets lost at that boundary, sometimes in translation? And as you think about it from your experience, what would it take to lose less of what gets lost? What would that look like?
Okay, I'll start for a change. So I think that's an easy answer. It's the lived experiences. That's the one thing in my own experience, working with policymakers across the globe, different levels of governance, and as a researcher, has been lost all the time. The lived experiences are much more, and they are disguised as lower ranked evidence. Somebody mentioned about evidence. We should reimagine evidence and reimagine how we think about that. So the lived experiences are perhaps the one most important evidence piece that should start from. And as an academic, I see many times, I have done that myself, and we started, what is out there? No, let's synthesize the evidence. Let's see the hypothesis. And then we put that aside in a way. And we are seeing that now we are doing a project in Brazil with affordable housing, and so much was revealed from the people that are living in places. They have to deal. I'll give you one very good example. We heard people that one thing they have to deal every day, and it is not captured by the government, is not captured by the surveys. They have to negotiate with the gangs. They are dominating the affordable housing, project. And they just see, if we are doing a survey, we report higher crime rates and people are walking more, for instance. Say, that doesn't make sense. But what people are doing, they are coping with the struggles, with the resources in place. And the gangs, in a way, they're sort of the resources they have in place. So to me, that's the most important element if I'm thinking about a housing solution that deals with the real life. So long answer, but it's lived experiences, I guess. Yeah.
I'm happy that I can follow you because I would simply just layer on. If you know me, then you know two things I really stand by are both relationship and trust. And it's important for me to always explicitly state that trust is not a competency that you can train into someone. Trust is a decision that can only be made after a relationship is built. And what I realized is, and I got this from Jobs with Justice, agitation outside of relationship is irritation. So it's really important that we recognize how powerful relationship is. It's actually the greatest currency. So when I think about COVID-19, for example, it wasn't a communications problem. It was really a trust and relationship problem because of those who were communicating. I also think that as we, start to reimagine what trust and relationship can look like, we have to take ourselves out of the things that feel the most common, which are better abstracts or new op-ed or refined language, and really think about creative structures. So I have 3 examples that I'll leave with you. The first is to lean into imagination as infrastructure. The very ability to see and think of a new way of being is a power and a capacity that many people, 1, don't have, and that 2, does not often get funded, recognized, or resourced. It is because of my prophetic imagination that I have the privilege to lead the organization I lead today, because it didn't exist. And had I sat where the community or where our society was asking us to stay, it wouldn't exist. The second thing I'd offer is to simply be honest about the self-interest. We all have very specific goals, and that transparency and radical honesty will dismantle many of the silos and resistance that we experience when we instead sit at the table and act as if we are all on the same page, when sometimes we don't even know what the other person is saying. And then the final example that I give, and I've mentioned this before, is co-ownership. It is very important that things are not created individually, because sustainability, as I mentioned, starts from the neighborhood level. So the opportunity to co-own, co-investigate, co-create, it's not just a buzzword. It is actually integral to whatever we decide to build, not only for translation, but for sustainability.
Thank you.
I mean, there's nothing else to say other than this.
Amen.
Is that if we let you lead, then we would not have a problem, right? That in education, we need to let people lead.
Thank you, thank you, thank you. And with that, I know all of you have things you're burning to ask, so the microphones are open. And Courtney, I'm sure we have a few from Zoom as well, but anyone who has a question in the room? Yeah, please, please. And don't be shy about going to the mic. I know it seems intimidating, but we don't bite. I promise.
Well, thank you so much, CJ.
And could you introduce yourself just briefly?
Oh, well, yeah. I'm Juliana Castellanos, and I work here in WashU. And I really appreciate the way that you are talking, because it's very inspiring. Like, everything that you are saying is like, I'm trying to keep note of everything, because it's really important. And one of the things that it really caught my attention is that you say to bring to the table the people that were closer to the pain, right? Something like that. And I've been noticing that as Hispanic, there are not many people on the table in the spaces that I am. And that has forced me to speak up for my people, right? So it's like, there are obstacles, like our people have less access to education, our people have less access to these spaces where the power and these conversations are happening. I'm doing a master's in public health in this moment where they say that the new wave of public health is centering community. And I wonder what were they teaching before, if that's the new wave. My comment goes to, what do you think about how can we bring, and I have an idea, but I want to hear your thoughts about how can we bring our people to the table and to these conversations when there are so many barriers for us to be there? Thank you.
I first want to just say thank you for the question. I do believe that there are a variety of approaches. So what I'm going to say is simply one option, but there are many. My immediate reaction is that we have to be very attentive to the positional power that we have when we are in places and spaces where we recognize there are not enough. I think that also causes us to be, as I like to often say, a disruptive innovator, and there's a way to do it. The first is to be radical at the table so that when you bring some of your friends and counterparts, it's no longer an anomaly. It's no longer, wow, this is so cool to see X, Y, and Z. They're actually used to the way of being because you've been yourself the entire time. I also think it's important to make sure that the space is safe. Every space that we desire for our neighbors or our counterparts to participate in are not always safe because they're not always ready. So sometimes we take the time and we yield the urgency to ensure that the table is prepared for such radical disruption. And then we bring in those who would love to be a part of it. And what we do is pass the mic. We no longer have to be the voice of because it's tiring, but we've had the chance to do things at a dual approach where we're building capacity in our own spaces that we know are safe, and we're priming the table accordingly as we prepare to make that intersection. I hope that helps.
I just want to add, though, it's not just, I mean, what you said, amen. It's not just, though, the need to prepare the spaces for to make them friendlier to community members to be able to be a part of those discussions and to be at the table. It's also sometimes preparing places for leadership that looks different, right? That shows up differently, because sometimes they're not ready for that either, right? A board will think, oh, we're appointing our first woman, our first person of color, and then they show up and they expect them to be in the same vein of everyone. And that's just, so there are oftentimes that institutions also don't do the work that they need to do also to be welcoming of a different kind of leadership as well. And to that point, I want to ask a question about institutions, and I'll get you in on this too. And that is not just what do communities need to do in this moment in terms of creating change, but what do institutions, like if there's one thing that you could think of, like what would the one thing that institutions that all of you have worked with, right, and dealt with, what do we need to be doing? What do institutions need to be doing differently?
Yeah, so I'm going to say we are at this place right now because institutions have not been really connected to the mission or their community. And so we talk a lot about the purpose of research. And I can tell you from law schools, we don't write as much as you do. And as a law professor, I don't care if I write another law review ever again, because that's not going to change or improve anybody's life. And so that's not the goal of my research. That's not the goal of my job. The goal is to teach students how to be connected to integrity, equality, and how to connect and go out into the community and serve them, right? And so when I do grants, I actually had a grant here in St. Louis around housing, and I didn't do housing, so I went to the community groups that did housing and say, okay, what is your biggest thing? Okay, that's what we're going to do. and then supported them in the additional work that they wanted to do, brought them before the funder, still work with them, because that is the point. Right? It's not writing another paper. It's not my idea. Like, I come with an idea and then I listen to them and move forward. So to me, institutions, we can no longer say that we are committed to the community just because we got another grant, because we got another Peace Award, because somebody published an article is on TV. At this point, people are dying, and that doesn't matter, right? And so we have to show up different. Well, your community group shouldn't have to come to university. We should be going out to you. Why are we stuck here, right? If we are not connected to community, then we are not doing what we're supposed to do. I do want to say this last thing, is that institutions did not start speaking up until they lost grants. And by then, they had lost the trust of community because people were under attack before then. And they keep talking about it in terms of grants. I don't care about grants. I say that, and I have 2 grants, but that is not the key, right? But the grants are to do good, right? And that's why you keep getting grants, so that I can keep paying people and keep moving them up and addressing their struggle. So if you keep leading with, we got to change words because we worried about grants, I'm not with you. And the community is not with you, because how does that help them when they're under attack by ICE? When they have food no more, when they're getting put out? We have to be connected to our humanity, and that has to lead us in what we are doing.
Professor Reyes, on this same point, I'd love to hear. Yeah.
Open one door with dozens of doors behind. So I think, now I'll make 3 points. One, we should not, and you say institutions, you're talking about universities, but I think,
I'm not just talking about universities.
I'll go back to the institutions, plural. But so science should be more transformational, less performative. That's an issue that it's across the globe. It's not WashU, it's everybody. Now, we are valued by performative science, not by transformational science. Transformational science has been measured by patents, inventions, as a proxy. Then that evaluates the core disciplines we need for the foundational transformations, humanity, social science, and so. So I think there's a systemic issue that is not WashU related. It's globally related to science. And so that's multiple hats, because I'm editor in a journal too. And I think that's an issue that as scientists, we should be talking about. What is transformational science? And that should be valued in age, NSF, and Wellcome Trust, and so and so and so. So the metrics should be adjusted and everything. But maybe that's another forum that Dingalia can lead for conversation. So I think that's one point for the scientific world. The second point, institutions as a whole, the issue of trust is not in academia, it's everywhere. If you go to any community in Brazil, the issue of trust is there with City Hall, with the politicians, with academics. It's a global problem of trust. So building trust is not only a problem that we are facing as academics, everybody's facing now. So one thing that I think we should be doing to build trust is talking about the issues, right? I think basic relationship 101. Just talk about the issues if you want to build trust, like we are doing today. So that space to talk about the truth that you think we are speaking on, because that's your truth, right? And the ability of listening to somebody else's truth without getting distracted by the things that trigger your reaction. I think that's the issue. It's very hard today. Engage in thoughtful conversations across the board, within academic institutions, in communities, with city halls, and so and so. So that's I think, talking about issues. I think that's the one thing, I guess, it's important. And the third one is just, if if you want to make a difference in the work we do, maybe we should be asking, are there any examples of transformational change that has been made we can actually copy? I'm not talking about academics only, across the globe, different examples in community. Are there any good transformational examples we could mimic? I love the way it was framed today about being more creative. I would take that with me today, all day. Being more creative and thinking about solutions that have been placed, but we have not really valued. Maybe that's my 3 bullet points.
Thank you so much. I'm gonna not put any pressure on you at all, but this will be our closing question of the panel. So, no pressure.
All right, I'll make it count. I'm Liz Chirel. I'm a professor of sociology here at WashU, and I feel so fortunate to have been in the room today. This has just been such an extraordinary convening. After listening to these 2 panels, I'm thinking about the relationship between destruction, creation, imagination, and culture. So CJ, I was really struck by this exchange between CJ and Rakaya, where CJ talked about that 2-loop model and said, we're dismantling one thing while we're building up another. And Rakaya said, we don't have to dismantle. That's not our job. We can build. And I'm thinking about how that articulates with Marlon's point earlier, where he urged us to think about culture and be creative and foster creativity in others. And one of the problems with culture, I think, is that it can be constraining. It creates a set of tools that come out of a problematic history. And so how do we navigate that? So my question is, how do we build something new with tools that have been used to do harm? Do we set aside those tools? Do we refashion those tools? What might that look like?
Great question. Thank you.
The question is phenomenal. So I am processing externally as I give a response. I think that 2 things can be true, and I truly do appreciate the tension that was raised here. As I think about dismantling, it doesn't always mean destroying. I think about it as an onion when you peel back the layers of things in order to further understand either why they exist and or should they exist. I'll give a very realistic example as we think about the institutions that we represent. The first thing I would challenge us to ask ourselves is, am I prioritizing the comfort of my institution or the comfort of those who my institution was created to support? And then when you think about that reality that there are many people who we serve either as a student or as a beneficiary or as a client who don't get the privilege to step outside of the structural racism that exist around them, and don't get the privilege to lean into comfort the way that we do when we represent an institution. The second thing I'd say as we think about dismantling and having tools that currently exist is to reimagine. So in our board meetings, we don't use Robert's Rules of Order. We actually use consensus. In that consensus framework, we use Fist to 5. Now, it took us some time to really train and explain what that means. And for some, it could feel messy. But for us, it ensures that everyone who is sitting around the table has been heard and has indeed spoken. No formal I, and if you object, you actually have to visibly show how you feel about a statement. And then I challenge us to think about how many of our institutions center in dominant culture, things like documentation or the way we set agendas. What about the people on your team who may be more artistic and would like to do a poem to share their objectives, as opposed to a top 3 on the top of an agenda? So there are ways where the structures do serve us, but the way we reimagine those structures and how it benefits those that we are positioned to support are opportunities that I would suggest to do a both and.
Is it working now? Okay, good. So for me, what I'll take today from this conversation with CJ Walker, with Professor Race and Professor Yerby, and I suspect others will too, is the insistence that community power is not a supplement to structural change, but a precondition. And we've heard that theme throughout the morning, actually, that the people closest to the pain have to be closest to the power. And that this is not a rhetorical commitment. It is an institutional one, a legal one, a design one. And we heard this morning about the evidence and about the ethics. That panel reminded us that neither is sufficient without the institutions, the legal frameworks, and the built environments. I want to step back for a moment and take stock of what we've actually done today and last evening, even at dinner, which started, I think, in that moment. We came together this morning with a shared conviction that racial health inequities are not inevitable, and that they have causes, and that those causes can be named, and that naming with rigor and honesty is a first step toward changing them. What I've witnessed across these 4 hours is a community of scholars, practitioners, advocates, and community leaders doing exactly that, with clarity and with courage and with a seriousness of purpose that I genuinely find not only moving, but inspiring. And God knows we all need a little bit of inspiration these days, and you all provided it in abundance, so thank you. Mary Bassett's keynote set the terms with characteristic precision that health is political. I loved the contextualization, the decontextualization that you provided, and that the structures producing inequity are legible if we choose to see them, and that seeing clearly creates an obligation. The morning's first panel also took the charge seriously, exploring the evidence and the ethics of translating scholarship into action. And that conversation, the one that we've just concluded, reminded us that action, to be real, must be accountable to the communities that it also claims to serve. I don't think it's possible to gather like this in April of 2026 without acknowledging the moment that we're also in, and many of you have done a version of that throughout our time together. The infrastructure of public health in this country, the research funding, the data systems, the agencies, the commitment at the federal level, and even to even measure racial disparities is under sustained pressure in ways that were difficult to imagine not so long ago. And that work is convening, the work this convening represents is not merely academically contested, it is in many places politically targeted. And so what strikes me too, looking around this room, is not just the quality of the thinking, though that has been extraordinary, it is also the resolve, the fact that people chose to show up, to speak plainly, to refuse euphemism, and to insist on the words structural, the words racism, the words equity, not as provocations, but as precise descriptions of a reality that demands a response. That matters, and it matters in this moment more than I can say. Convenings like this one are not peripheral to the work of health equity, they're constitutive. The relationships built in rooms like this one, the arguments that get sharpened, the collaborations that get begun, these are what allow the work to continue even when the winds, as they are these days, are unfavorable, and especially so then. None of what happened today was inevitable. It required vision, partnership, and an extraordinary amount of work by a few people who also deserve to be named. This symposium grew out of a partnership that I value enormously with Dean Sandro Galea and with the WashU School of Public Health. Sandro, your commitment to bringing the full weight of this institution to bear on questions of racial health equity and your willingness to make this a genuine joint endeavor made all the difference, and I thank you for that. And the partnership would have remained an idea without the people who turned it into an actual day. And I want to recognize among the many of you, because there are many of you and I can't name all of them, but I do want to recognize two colleagues especially whose work made this event not just possible, but excellent. and that is Courtney Babcock, who I think just stepped out of the room. Oh, no, there she is. Okay, in the front, yes. In the School of Public Health, brought professionalism, care, and remarkable good cheer to every dimension of the logistics and planning of this event. And Dagam Gabriel-Michael, Dagam is here as well. Dagam works with us at CRE2 and brought that same quality of attention and skill to our side of the house as well, and I'm very grateful. Both of them worked with a kind of quiet, expert dedication that is easy to take for granted in a moment and impossible to replace. Please join me in thanking the two of them. I also want to express our deep gratitude to Chancellor Andrew Martin and to Washington University and St. Louis more broadly. We're living through a period in which universities across the country are making difficult choices about what they will stand behind and what they will walk away from. And I'm grateful, genuinely and specifically grateful, to be at a university where this work is not merely tolerated, but is supported, where the commitment to truth and to the public good has not bent. And that is not something that I take for granted, and I don't think in this moment any of us can. So to our keynote speaker, Dr. Mary Bassett, thank you for opening the day with the seriousness and the moral clarity that it deserved. To the scholars and practitioners and community leaders who joined us on both panels today, Professor Marlon Bailey, Professor Bettina Drake, Professor Karen Joint-Maddox, C.J. Walker, Professor Rodrigo Reis, Professor Rakaya Yerby. You gave this room much to think through and to act on, and we're all deeply grateful. And to everyone in the room and to those of you who joined us online, for being here and for staying through the morning and for asking questions, thank you. The quality of a convening like this one is made much more by its audience and its speakers, and the audience today has really been exceptional. C.J. Walker, from another context, recently said something that I keep returning to. She said, "Constraints are what we make them, and we get to show people how to remove them." I think that is a good charge to leave us with, that the constraints are real, the moment is difficult, and we get to decide together and in this work how we work to remove them. I want to thank you all. Please enjoy the beautiful lunch that we'll be providing right after this. Continue the conversations. Please stay in touch with one another. That is how this work will continue to live beyond our gathering today. Thank you.